Yeah.
Webinar is always better.
Yeah. So we are live in 3, 2, 1. Go, sir. We are live now. Good to go, sir.
Good evening, everybody. Welcome to the third webinar on epilepsy surgery conducted under the auspices of Indian Society of Stereotactic and Functional Neurosurgery. So far, we've covered the interesting topics of stereotaxy, and the second topic which has been covered is epilepsy. We finished two webinars on epilepsy covering the pre-surgical evaluation as well as investigative techniques, and we've seen the use of recordings and stereo EEG in the last webinar. A very interesting webinar is coming up today where we discuss the surgical techniques, detailed surgical techniques about temporal lobe surgery, hemispheric surgery, followed by newer techniques, and finally to end with is neurostimulation. Uh, to moderate this session, we have one of my close friends, Dr. Dattatreya Mazumdar, Professor of Neurosurgery at SID GS Medical College and KEM Hospital, Mumbai, whose personal interest in epilepsy surgery is known to everybody. With this, I'd ask Dr. Dattatreya to take over the proceedings and moderate the session.
Thank you, Milind, and welcome everybody. I think Milind has given you the brief introduction about the motive of the ISSFN, which is more of a teaching kind of a webinar. So, without wasting time, we have an august faculty here. I would request Professor Malla Bhaskar Rao, who is a professor of neurosurgery at the NIMANS Bangalore, which is Institute of National Eminence, and his interests in epilepsy surgery are known since long time when he was with Sri Chitra Institute of Medical Sciences at Trivandrum. So he has vast experience in the field of epilepsy surgery, and his topic today will be surgical management of mesial temporal sclerosis. So I would require Professor Bhaskar Rao to give his lecture. Thank you.
I hope you can see my presentation.
Yes, we can see your presentation.
Yeah. Good evening to all of you. Thanks for the opportunity. I have no financial disclosures in this presentation. Let me start with a few well-known facts. Mesial temporal lobe epilepsy associated with mesial temporal sclerosis is the most common form of human drug-resistant epilepsy. Anterior temporal resection is the most common epilepsy surgery procedure performed worldwide. The identification of candidates is relatively easier. Surgery is standardized and the outcome is good. All this is because both the lesion as well as the focus is confined to the mesial temporal structures. The effort is less here and the impact is maximum, whereas the effort is maximum here and the impact is minimum. If you start here and stay here, you will get maximum benefit out of the epilepsy surgery programs. Of course, you should be familiar with the more difficult management of more difficult cases, but really it's difficult to manage these people without institutional support. With that in mind,
Bhaskar, your screen is not moving forward, I think.
Yeah, is it okay now?
No, we are not. I'm sure it's not. It's coming very. It's stuck somewhere.
Okay, I think I just have to restart.
Yeah, just restart. Yes, yes. Now it is seen.
You can see now.
Yes, yes. Now it is seen.
So to understand the anterior temporal resection in the
But it is, we are not seeing the entire thing. Only something outline is seen.
yeah, I okay, I'll try to move the cursor. No, can you see now?
Yeah, 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 yeah. It is just
So,
started.
so to understand anterior temporal resection in the right perspective, this is how I have organized. I will start give you a brief historical perspective, take you through the anatomy of the mesial temporal region, and then show you one surgical technique, and then share some of the lessons which I have learned over a period of time. So in France, the hippocampal sclerosis was identified 200 years ago in among people who died following epilepsy. And even Hewlings Jackson, about 130 years ago, mentioned about the relationship between this mesial temporal epilepsy with structural substrate. Even the histopathological, the cytoarchitecture of the hippocampus sclerosis also was described almost 130 years ago. But one may wonder that why there was no surgical intervention for hippocampal sclerosis. The prevailing concept in those days is the hippocampal sclerosis is the consequence of epilepsy, but not the cause of epilepsy. Of course, there was great progress in understanding post-traumatic epilepsy following the First World War, and using the principles of the post-traumatic epilepsy. This is how Wilder Penfield performed the first anterior temporal resection almost 100 years ago. And Penfield's approach is more lesion oriented. And of course, subsequently, following the description of Easy by Hans Berger, the Gibbs and Bailey from United States started operating based on the electrophysiological focus rather than the anatomical lesion. Subsequently, Penfield and Jasper uh, uh, largely by reviewing the failed epilepsy surgery procedures, identified the role of mesial temporal structures and incorporated them in the subsequent resections. Um, Murray Faulkner at Maudsley Hospital started doing en bloc resection, documenting the proper histopathological changes, and he's the one who coined the term mesial temporal sclerosis. And Niemeyer from Brazil came with the selective amygdalohippocampectomy approach in the late 50s. There was a worldwide interest in epilepsy surgery, and a large number of procedures were performed at the Madras Medical College as well as Christian Medical College, Vellore. Of course, subsequently there was a decline in 70s, not only because of indiscriminate use of epilepsy surgery, but also because of advent of drugs like phenytoin and carbamazepine. And of course, there is a revival of interest in the 80s, again, largely due to better understanding of the natural history of surgically remediable lesional epilepsy syndromes, mesial temporal sclerosis being the prototype. Here you can see the sclerosed hippocampus with distorted internal architecture, and ventriculography showing the enlarged temporal horn. And this is the CT scan, again showing the enlarged temporal horn. And of course, now we know that with MR, the condition can be identified so easily. So coupled with advances in imaging as well as video easy telemetry, there was a revival of interest in epilepsy surgery programs. And also there were advances in surgical techniques also. For example, Dennis Spencer came with his modified temporal resection, and then S.R. Gill came out with again revival of interest in the selective hemiclohippocampectomy. So it became technically more intensive, questioning the feasibility of developing epilepsy surgery programs in the developing world. So fortunately in India, the national institutions have taken a lead. Sri Chitra All India Institute of Medical Sciences at Delhi and NIMHANS Bangalore have taken a lead and established model programs. Now, over the past 25 years, over 10,000 epilepsy surgery procedures were performed in India across 40 centers. Nearly 80% for anterior mesial temporal lobe epilepsy. With that background, for those aspiring young neurosurgeons, let me give you some idea about the mesial temporal anatomy. Mesial temporal anatomy is complex but constant. This is what S.R. Gill has mentioned about Klinger and hippocampus. You see, hippocampus was the most complex structure in all of the nature, possessing qualities which are not immediately apparent from its confined anatomical structures. So let me take you through this interesting complex anatomy. I'm thankful to Dr. Andrew Parent for sharing these slides. Now this is left side Sylvian fissure, superior temporal gyrus, middle temporal gyrus, inferior temporal gyrus. This is the superior temporal sulcus, and this is the inferior temporal sulcus. There is no middle temporal sulcus. This is the occipital notch, and this is the parieto-occipital sulcus separating occipital lobe from the temporal lobe. This is the hippocampus. This is the uncus and parahippocampal gyrus. And fusiform gyrus. This is the lingual gyrus, and then this is the fusiform gyrus. This is the inferior temporal gyrus. This is the undersurface of the brain, and this is the uncus, optic nerve and tract, and this is the parahippocampal gyrus, and uncal hook and uncal notch. After removal of the parahippocampal gyrus, this is the inner surface. This is the line is hippocampal sulcus. This is the coronal section along that line, and this is the hippocampal sulcus. Above superior part is the hippocampus, inferior part is the parahippocampal gyrus. This is the collateral sulcus. Again, back after removal of the parahippocampal gyrus, hippocampal sulcus. This is the dentate gyrus, and this is the fimbrio-dentate sulcus, and this is the fimbria, and this is the optic nerve, tract, and lateral geniculate body, and then the Meyer's loop, optic radiation. This is the inner surface. This is the hippocampus joining the lingual gyrus, and also joining the cingulate gyrus, and this is the hippocampal sulcus and dentate gyrus, and this is the fimbrio-dentate sulcus, and this is the fimbria, and this is the collateral sulcus, and this is coronal diagrammatic view, inferior temporal gyrus, fusiform gyrus, and this is the collateral sulcus. This is the parahippocampal gyrus, and this is the hippocampal sulcus, dentate gyrus, and this is the fimbrio-dentate sulcus, and this is the fimbria, and thalamus and choroidal fissure. This is insula, a circular sulcus. This is the temporal stem transection leading to the temporal horn. This is after removal of the roof as well as the lateral wall of the temporal horn. This is amygdala, and this is globus pallidus. This is the hippocampus. This is the fimbria, and this is the cilium fissure, insular cortex, temporal stem, temporal horn, hippocampus, amygdala, globus pallidus. This is the line which separates amygdala with globus pallidus. This line is arbitrary line, and this is the line separating amygdala from globus pallidus during the surgery. This is the uncus, tentorial notch, posterior cerebral artery, oculomotor nerve, and optic tract. This is the coronal view starting from anterior to posterior, and this is the amygdala, and this uncus, and optic tract, and hippocampus. This is the temporal stem, and again optic tract posterior part, this temporal stem, a temporal horn, and hippocampus, and the posterior part of the optic tract. This is the para-hippocampal gyrus and the blue line collateral sulcus. This is the hippocampal head, and this is the para-hippocampal gyrus collateral sulcus, and this is the optic radiation posteriorly, and this is the intraventricular exposure. This is the choroid plexus, hippocampus head, hippocampal body, and hippocampal tail. This is the neurovascular bundle with arachnoid coverage, and this is after removal of the arachnoid. This is the PCA. This is superior cerebellar. This is the third nerve, and that's about the anatomy. Now, Professor Ghazi Yasargil mentioned that of all the neurosurgical interventions he has performed, most pleasing surgical experience for him is a resection of the hippocampus. Now, let me take you through one surgical technique, the way I do the surgery. Of course, you have to develop your own technique. Now, this is a young lady who presented with drug-resistant epilepsy since early childhood. See, if this is a static image, if you look at her posture, the posture is right. Hand, there's a dystonic posturing is there, and I'll just, yeah, you see there is a dystonic posturing of the right hand, suggesting that the seizure origin is from the left temporal with the propagation to the left basal ganglia, and here there is a ictal buildup of rhythm in the left temporal. This is the left temporal, and the right temporal is normal. So here you can see there is a left hippocampal sclerosis. There's a hyperintense signal. There's a large enlarged temporal horn. So she's one of the ideal candidates for left hippocampal resection. So this is the left side frontotemporal craniotomy. This is the left sylvian fissure, and this is the left temporal area. This is the left frontal. This is the initial neocortical resection. This is for specimen identification and orientation for the research purpose. Next is the subpial resection of the superior temporal gyrus, which will extend all the way up to the temporal pole, up to the even uncus. Now, there are two fundamental landmarks in the surgery. One fundamental landmark is the temporal horn, reaching the temporal horn. This is hippocampus. And this is the amygdala. Amygdala is the nucleus surrounded by the temporal stem of white matter. Now, this is en bloc resection of the amygdala. Amygdala is anterior and superior part of the temporal horn. This is the en bloc resection of the amygdala. The the next step is the opening the choroidal fissure. This is the head of the hippocampus, H. That's the fimbria, lifting the fimbria and also lifting the head of the hippocampus. That's the choroidal fissure. Hippocampus is about 4 to 5 centimeter structure. With in hippocampal sclerosis, there is a volume reduction. So usually about 3.5 centimeter structure is resected. Head of the hippocampus is being lifted, and just below, in few seconds, you will find the brain stem. So this is the body of the hippocampus. This is the fimbria. And this is the hippocampal sulcus, the second most important landmark in the surgery. First is temporal horn, second one is hippocampal sulcus. This is the sulcus. The branches to hippocampus from the both the posterior cerebral artery P2 segment as well as from the anterocoronal, they come into the hippocampal sulcus. All those branches have to be coagulated, cut, and then only we can resect the hippocampus. Otherwise, a traction can lead to spasm of the posterior cerebral artery. Here, the parahippocampal gyrus is being lifted from the base. So this is hippocampus, and then there's hippocampal sulcus, and then the other side is the parahippocampal gyrus, and then this is the en bloc resection of the hippocampus. The remaining parts like uncus and posterior hippocampus are being resected separately. So this is a herniated uncus which is being resected. Sometimes people can have bradycardia during this stage of resection because of dense adhesions. So you should take your own time and then resect slowly. So this is how it looks like the resection cavity. You can identify the posterior cerebral artery, cerebral peduncle, as well as the anterior choroidal artery. This is the resection cavity, MR done 3 months after surgery, as well as the histological image of the same patient showing a loss of neurons in the CA1, CA3 as well as CA4 regions. These two postoperative MRI showing complete resection, histology showing definite evidence of hippocampal sclerosis. They are two robust predictive factors of good seizure outcome. Now, over the next few minutes, I'll take you through some of the lessons which I have learned, which may help the beginners. Now, when you start the epilepsy surgery program, please don't expect that patients will be lined up outside your clinic. Most of these patients with drug-resistant mesial temporal lobe epilepsy, they're all hidden in the community. There should be an active effort on your part to reach out to these people along with your entire epilepsy team. You should play an active role, and your role as a surgeon should not be confined to technical aspects. There are several types of epilepsy can propagate through hippocampus and mimic like mesial temporal lobe epilepsy, and you should be familiar with this temporal lobe epilepsy syndromes. And also, uh, even among people with mesial temporal lobe epilepsy or temporal lobe epilepsy, there are several subgroups are there. So you should be familiar with all these subgroups. Even the epileptogenicity of different mesial temporal structures which I showed varies from person to person. So you should develop some way of understanding by semiology, by EEG, by MRI, and by operative findings to know to what extent these structures are involved. Eventually, this knowledge will help you to develop selective as well as super selective epilepsy mesial temporal receptive strategies. Of course, you should, based on the standard guidelines, you should develop your own operative technique, and also should be familiar with selective amygdalo hippocampectomy, both technique as well as different approaches. You see, now there are 8, 9 different approaches are there. All these approaches are basically to reach the temporal horn. Once you reach the temporal horn, rest of the surgery is more or less similar to the video which you have seen. Now, you're all familiar probably with this Canadian study. What I want to show you is that in this class 1 study, 40% of people failed this epilepsy surgery. So in your practice in future, with meticulous, by understanding the reasons for failure, by meticulous case selection as well as by surgical technique, try to avoid these surgical failures, improve your outcomes to more than 60 to 70, 80, 90, as much as possible. Also, same way, there are known complications are there, but try your best to minimize and avoid these surgical complications. You should be knowing alternate options also, like for example, radiosurgery, hippocampal transections, and laser ablative procedures, as well as hippocampal stimulation. You should be familiar with these techniques. And once you remove the hippocampus, please don't throw it. It's actually like a gold mine. If you have facilities for doing tissue research, do it. Otherwise, you send your material to one of the centers accessible to you, which is involved in this epilepsy research. And I wish India can have a tissue bank, just like European epilepsy tissue bank. Now, this my team, just like my team, you should have a good team. There should be a team with a good team leader as a nucleus for the program to take off. I hope some of you will take it up and then take it forward, and then I wish you the very best in your future endeavors. And then thank you very much for your attention. I'll stop with this.
Yeah. Thank you, Professor Bhaskar Rao, for a nice lecture. I think the basics of the mesial temporal lobe structures, which is a gateway to understanding epilepsy surgery, has been quite nicely elucidated. And the video was also very good. I think it says it all. It looks very simple when Professor Rao has demonstrated, but it is quite complex. Let me tell you that. I think each one of us has taken minimum 3 to 4, 5 years to understand what is hippocampus before we really ventured into it. I think we will go to the next lecture before we take the discussion. I'm glad to introduce my senior colleague from KM Hospital and now at Hinduja, Dr. Milind Sankhe, who is the consultant neurosurgeon at the Hinduja Hospital and Wadia Children's Hospital in Mumbai. He has a vast experience in functional neurosurgery, which includes epilepsy surgery and movement disorders. And he runs a very successful clinic at the Hinduja Hospital in Mumbai. He is going to talk on posterior quadrant disconnections and hemispheric disconnections. And over to you, Milind, for the talk.
Yeah. Can you see my screen, Datta?
Yes, we can see it. Thank you.
Okay. So, good evening, everybody, and thank you, Datta, for the kind introduction. So, as Dr. Malla Bhaskar Rao was mentioning a short while ago, that temporal lobe surgery, particularly surgery for MTLE, is one of the initial steps and definitive steps yielding up to about 60% benefit from surgery and surgical intervention for patients with MTLE. A similar pathology, but probably a little less understood and probably less ventured into purely because of the complexity of the surgery and the initial complications which were noted with the hemispheric procedures, have been a little deterring factor for the epilepsy surgeons. As of initially, when you're starting, you don't want any major complications to happen into your practice. So one of the most definitive substrates for epilepsy is hemispheric pathology, and hemispheric procedures have yielded very, very good results with benefits in the range of about 80% seizure freedom. Papers vary from 67% for patients with hemimegalencephaly for those patients who have infarcts involving the entire hemisphere have much better results. So this evening, what I'm going to try and do is to give you a perspective as to the evolution of hemispheric procedures, as to why have we reached a stage of disconnection. Then try and define disconnection with a bit of anatomy at each stage, define the hemispherotomy technique, or rather discuss the hemispherotomy techniques, show you a video of hemispherotomy, then discuss the bit of anatomy of the TPO surgical technique, discuss the surgical technique, and a few examples to end with the talk. So, as we know, historically, Walter Dandy initially performed the first anatomical hemispherectomy for the treatment of glioma, and he thought at that stage that probably removing this will take care of the glioma and be a curative procedure. It never happened that way, though, but it definitely helped the epilepsy part. Similar papers were read with by Mackenzie from Toronto, and Kralnau reported 12 cases in 1950. This statement, which was made by Northfield and way back in 1973, still holds true, just that some words have been replaced now, that it is not a hemispherectomy, it's a hemispherotomy, and it is not fallen out of favor now. It is actually very much in favor because it is so much less invasive. So what are the pathologies that we are looking at treating? And these are fairly common pathologies such as multilobar dysplasias, complete hemispheric dysplasias, hemimegalencephaly or Rasmussen syndrome, or a perinatal stroke, Sturge-Weber syndrome. So the aim of the surgery for a hemispheric procedure as such, or for a hemispherectomy, initially was to either remove or disconnect a part of the pathological hemisphere generating epilepsy in order to stop the epileptic connections from the healthy hemisphere and prevent any delayed complications. Now, as we all know, anatomical hemispherectomy initially was described by removing the entire half the lobe, but we can understand the morbidity that goes along with it. Later on, it was thought that it is probably not necessary to remove the basal ganglia, and more work started being done with preservation of basal ganglia. As we all understand, such a massive tissue loss, particularly in children, can lead to a major, major volume loss in the body. And we've all known about the long-term complications of late hydrocephalus, superficial cerebral hemosiderosis, We've known in terms of damage to massive subdural cavities, which can lead to massive hematomas inside it as well. So multiple modifications came in later on, where you could plug the foramen of Monro so that the CSF, ventricular CSF cavity was isolated from the subdural cavity. Further modifications came in the form of a functional hemispherectomy, where you did not remove the entire hemisphere and you removed only a part of it. And unfortunately, in those days, the part which was removed was, and I believe that at some places this is still practiced though, you remove the posterior frontal area and the motor area and remove the temporal lobe and get access to the mesial structures in a way like this, as demonstrated in this graphic images. However, again, the same problems remained. Hydrocephalus still continued as a major factor. It was still time consuming and obviously a significant tissue loss and a blood loss. The shaded areas seen in the orange are the areas to be resected, which is still a large area, and which meant that it used to be a massive exposure still. So these are some of the initial pictures and images which we used to practice. And these are the large scalp flaps which were conducted in those days. And you can see this sort of a large scalp flap in a child, particularly a young neonate, can be devastating from the blood loss point of view as well. This is one such video of our initial hemispherectomy, and you can see such a large tissue which is removal, particularly in a child, can be quite devastating from the volume loss point of view, leaving a very large residual cavity with multiple blood transfusions needed during the surgery. And obviously the longevity of surgery also brought into picture the hypothermia that went along with it and prolonged anesthesia complications. If you didn't do an anatomic and you left some bit of temporal lobe, left some bit of occipital lobe, you still had a massive cavity. And one of the major factors, again, the communication with the opposite ventricle through the foramen of Monro. And this is just trying to show you the foramen of Monro out there and the communication with the ventricular cavity, opposite ventricular cavity. And such a large area of tissue, such a large tissue loss would mean that there would be a large subdural cavity as well. And these are some of the post-operative images following a hemispherectomy procedures. Some of them are anatomical hemispherectomies, some of them are functional hemispherectomies, and the arrow, particularly orange arrow, is trying to point out towards a plug which has been put there at the foramen of Monro to prevent communication from the contralateral lateral ventricle into the subdural cavity at the surgical site. So the complications still remained: a large subdural cavity, the hydrocephalus, and prolonged complications such as superficial cerebral hemosiderosis. So the major issues with these were blood loss, prolonged exposure, tissue loss, hypothermia. Fever, which I didn't mention, is something which was a major issue because of the significant amount of blood trickling into the subarachnoid space and the neck rigidity leading to meningism. So the focus shifted towards having a smaller tissue removal but maximum disconnection. And this is one graphic image to try and show you how focus has shifted from a large tissue removal to a minimal tissue removal, and focuses on more of disconnection rather than towards resection. So how do you define disconnection surgery? Disconnection surgery would be to surgically sever the neural connections aimed at stopping the propagation of epileptic discharges while preserving the blood vessels and the blood volume and the brain volume. So how does one go about it? And Villemure in 1995 described this technique of initially going by a peri-insular or a trans-sylvian hemispherotomy. And this is what is called as the lateral hemispherotomy. A lateral hemispherotomy is essentially approached from the lateral side. That means you do a perisylvian procedure or a peri-insular procedure, gaining access to the insula, going around the insula, and effectively then reaching the ventricle and then doing an intraventricular procedure. So once you have identified the insula, you are essentially entering in from the insula, one above the insula, suprainsular window, entering into the body of the lateral horn, and the infrainsular window enters into the body of the temporal horn. Essentially, you are completely going around the insula, around the creating a C, and that C is the lateral C, and then you incise the corpus callosal fibers on medially, but on the parasagittally though, not bang in the midline, and that is the inner C. So that creates the double C concept as such. I must admit, this is something which I used to practice heavily till one of my first cases in 2011, something which I landed up doing a vertical hemispherotomy for a patient with holoprosencephaly, and later on was quite inspired by the work which was done by my colleague and a friend Sarat Chandra, and essentially I have adopted a vertical hemispherotomy since then. So what is the difference between a lateral hemispherotomy and a vertical hemispherotomy? So Delalande in around 2007 proposed a parasagittal vertical hemispherotomy where he entered the ventricle from the surface, from the convexity. He entered the ventricle, however, by making a parasagittal cortical incision and entering the ventricle, ipsilateral ventricle, and then working from inside. This was again, you can see the illustration, the graphic, the pictorial diagrams which are drawn there. And this pictorial diagrams try and show you the cortical window. The cortical window is once showing an entry into the lateral horn, and essentially from there you enter into the temporal horn. Now, this is quite easy for me to mention, but it is not necessarily easy conceptually to grasp. And I'm going to make some effort to try and explain this. And this is a summary of the images which I'll be showing you in the future. The blue represents a lateral hemispherotomy, whereas the green represents a vertical hemispherotomy. A lateral hemispherotomy is a lateral approach, whereas a vertical hemispherotomy is a parasagittal approach. So you can see that the whole aim of the procedure is to try and isolate the entire basal ganglia on the ipsilateral side from the rest of the hemisphere on the pathological side. So these are some of the images which have been drawn by my junior colleagues, and this is a pictorial diagram. You can see I'm trying to correlate this with the MRI images, and this red line essentially shows that the anterior extent of your disconnection, which is coming bang in the midline all the way and entering through the lateral ventricle, disconnecting the corpus callosal fibers, going lateral to the caudate nucleus, but you are medial to the external capsule or the extreme capsule. You do not need to enter the insula, or you do not need to enter the sylvian fissure. And as you extend the lateral disconnection posteriorly, you communicate that with the atrium, and you reach the midline. And the posterior disconnection is a very straightforward procedure done at the end by disconnecting the tapetal fibers entering into the splenium. So this is an action image. I'll try and get that correlation for you on the coronal image. Now I'll go to the second image first, and I'll draw your attention to the left-hand side picture, which is the diagram which has been drawn here. You can focus, there is an orange line and a blue line. The orange line suggests a parasagittal window, whereas the blue line suggests the interhemispheric window. So if you're entering in from a parasagittal window, once you've made a cortical incision, the aim is to try and enter the ventricle after doing a callosotomy. It is a parasagittal callosotomy. It is not a midline callosotomy. It's a parasagittal callosotomy. Once you've entered, then you go lateral to the caudate head, and then again lateral to from there you go further lateral to the putamen, but you are still medial to the extreme capsule. And once you are in, you continue with the lateral disconnection, you will be able to reach the temporal horn and remove the amygdala as such. So the MR correlation with the same is quite easy for us to make out that but however, the MR imaging, here the parasagittal line is not drawn. It is purely an interhemispheric approach. The interhemispheric approach is no different from a parasagittal approach, that the interhemispheric approach is clearly giving you a ready-made plane between the dura and the ipsilateral hemisphere. And once you've done a colossotomy, which is slightly off the midline, over here the pictorial diagram shows it to be bang in the midline, but it is off the midline on the side of the pathology. So this is the interhemispheric hemispherotomy or a vertical hemispherotomy, essentially showing the same thing. And I'd like to draw your attention to the fact that you do focus on removing the amygdala at the same time. So this is one such effort to try and correlate anatomically as to how would you approach. This is a video which I'll take you through. Hopefully, this video is going to be good enough to give you an orientation. So this is an endoscope assisted. This is something which I was inspired by Sarat's work. So once you've done a colossotomy, you've finished the splenial dissection, you're into the temporal, into the lateral horn, and now in the anterior, you're doing the frontal base disconnection, and you're essentially tracking the A1, A2. And once you've done the A1, A2 disconnection, you are doing the lateral disconnection, reaching the temporal horn. Here we are into the temporal horn and just extending it slightly posteriorly. As you extend it posteriorly, you will see the hippocampus now. That's the hippocampus which is identified. You complete the amygdala excision right there. Once you've excised the amygdala, you extend the lateral disconnection posteriorly, complete the posterolateral disconnection and the posterior disconnection. This is the post-operative MRI scan along with DTI, which is performed as a regular thing. So to take you through the actual video of the post-operative MRI scan, you can see the images going from front to back. Essentially, you can see the interhemispheric approach, the line of disconnection, which is coming all the way. The basal ganglia is preserved, and you've entered this is the posterior aspect of the temporal, it was from front to back. And you can see the same thing in the actual slides. This is probably much better to do a vertical hemispherotomy because it avoids working around the insula. The moment you stop working around the insula, the chances of damage to the insular vessels is much less, and preventing any form of an infarct due to the spasm of the vessels which happen around the insula, or for that matter, even the PCA territory infarct, something which is demonstrated in one of the cases which is done at our center. So are there definite advantages of vertical hemispherotomy over a lateral hemispherotomy? According to me, yes. The seizure freedom is similar in both the cases. Obviously, insular resection is not necessary in a vertical hemispherotomy. Essentially, it is a disconnection which takes care of the insula automatically. Chances of a vascular compromise with an infarct, or with, for that matter, any form of spasm around the vessels is less, significantly less blood loss, because you're not really working around the blood vessels at all. You're essentially working all along the white matter. So it's an excellent approach and a much smaller skin incision and a craniotomy. Having given this perspective, I will come to the examples of hemispherotomy a little later, but I'd like to continue with the anatomical part and the TPO discussion. So coming to a next very good operation, which is disconnecting the temporal polar occipital pathologies. Now, this is a very, very good procedure which has been implemented in epilepsy surgery. Essentially, the biggest advantage of this is that it is sparing the motor area. So the moment you're talking about sparing the motor area, one needs to be very, very comfortable with the surface anatomy. And this is one such attempt, trying to correlate the MRI scan with the pictorial diagrams, which have been again kindly drawn by my juniors. So you can see over here clearly trying to identify the areas, including the sylvian fissure, the central sulcus, the precentral gyrus, the postcentral gyrus, the understanding of the supramarginal and the angular gyrus, and similarly the understanding of the sylvian fissure anatomy. Most important as far as the understanding of the cortical anatomy is the identification of the motor strip, and this can be, we all understand this and we all know this now, but nevertheless it becomes very, very important to try and preserve this when we are talking in terms of motor function preservation. So here is again correlating it with the MRI, and you can see the knob nicely with the identification of the central sulcus. and the precentral gyrus of the motor strip in front and the sensory strip behind. In the green is an effort to show the difference between the thickness of the precentral gyrus and the postcentral gyrus. It is also important to understand the cortical anatomy on the medial side, because that is equally important as you reach for a TPO disconnection. So here is the cingulate gyrus and showing the ascending marginal part, and just in front of it is the precentral gyrus. So coming to the actual surgical steps and what do we do, here is some pictorial efforts trying to show you and correlate it with the MRI scan. The orange line essentially is a line of dissection which is shown on the lateral surface. This is the lateralmost surface that you're talking about. And this is where you start by making a cortical incision. I'll show it to you on the video as we go along. This is as we do it from the top. And this is again something which you can see is behind the central sulcus, again reaching the midline. You have to remember over here that you have to disconnect the entire occipital lobe, and it is not purely disconnecting the occipital lobe communication with the opposite side. You need to disconnect the entire occipital lobe here. And this is on the medial side, again to try and emphasize the need to reach all the way. And the orange line clearly shows the demarcation all the way from on the medial side reaching till the splenium. So this is one video of a TPO disconnection. This is a video of a TPO disconnection. So a navigation helps very well, and this is a planning which is clearly showing, and I'll try and play it again. So if you can see, the whole thing starts off by showing the knob, and as you go along, you're just behind the central sulcus, reaching the sylvian fissure. Okay, and all through, and this is what the trajectory is, going from lateral to midline, and this is what we need to do. And these are some still images. This is the kind of positioning and the craniotomy that we plan. So once you've made a strip craniotomy, the sylvian fissure is open. Once you've opened the sylvian fissure, you make an entry by disconnecting the stem into the temporal horn. Once you've done that, I make it a point to enter into the atrium. And this is done by making a cortical window. Here is the entry into the atrium. And now you will notice that there is an effort made to preserve every vessel. An effort is made to preserve not just the veins, but even the arteries. And the small vessels are also to be preserved. Don't coagulate them and cut them, because that would be a big mistake. And here is a completion of the amygdala excision. Amygdala and the head is excised. And this is just a small part of the excision. The amygdala is supposed to have some communication with the opposite amygdala through the anterior commissure. So it is probably better to excise the amygdala each time. So once you've done that, on the medial side, you're doing a medial disconnection. This is bang close to the midline. And as you extend that medial disconnection, all along, you're staying subpially, and you are completely removing. And this is the image which you see at the end. And so these are the certain still images that you see. The whole thing is to make sure that you have preserved the vessels, including the veins and small arteries. And you have disconnected from lateral, starting initially from the lateral side and medially, going all along, excising the amygdala and making sure that the posterior disconnection is complete by reaching all the way up to the midline, and eventually disconnecting the fornix as well. So this is the picture over here clearly tries to show the same thing. And if I can draw your attention to the picture at the top, it clearly shows that there is all efforts are made to preserve the veins, and the disconnection is all the way in the midline, towards the falx. So these are the post-operative images of after surgery. This is about 3 months after surgery, and you can clearly see the demarcation line disconnecting the entire parieto-occipital dysplastic cortex from the rest of the brain, preserving the motor function. So what are the biggest advantages with any disconnection? As I said earlier, minimal loss of blood and brain. The theater time and the ICU time and hospital stay is well reduced. Surgical planes are relatively well maintained, and the post-operative complications are extremely minimized. So coming to certain examples now, this is the same child where you saw I think it's not the same video, but the post-operative images. And this is a child who's an 8-month-old child with refractory seizures, no deficits, no motor deficits, and MRI scan clearly shows a large parieto-occipital dysplasia with temporal lobe involvement as well, as you will see as the video goes further down towards the temporal lobe. So you can see this, the entire occipital lobe is pathological. And as you go enter the temporal lobe, here you can see the dysplastic cortex again. So this is the pre-operative and this is the post-operative video. You can see the line of disconnection coming up. And this line of disconnection reaches the atrium, disconnects it from the splenium, goes down to the temporal, and here is a line of disconnection in the temporal horn. So this is this very interesting paper which is published, which predicts the use of diffusion tensor imaging as to predict the motor deficit which may happen after a hemispheric procedure, or for that matter, any form of, and a decision to be made whether to conduct a hemispheric procedure and how to predict a deficit, particularly when the child has no motor deficits. So why do I bring this to your attention is for the next example. If you have an atrophic, suggesting that the fibers are clearly involved and that there is an established hemiparesis, then it is very likely that the hemiparesis will just worsen or will remain more or less stable. But if the fibers are more or less symmetrical, then the hemiparesis expected is going to be very, very severe. And this is something which we decided to, this is something which we use regularly in our practice. And here is one more example in a child who is currently still in the hospital. This is a child who's a 4-year-old child with daily seizures, in about 6 to 7 in number. Seizure semiology was, and the radiology was lateralizing everything to the left-hand side with a normal hand function. So the family was not keen on any form of motor deficits. So the option that was offered to them is that we will do a TPO disconnection, but we decided to do a DTI and try and predict what sort of a motor deficit we'll be giving the child should we do a hemispherotomy. And here we could clearly see that the tracts are well maintained on both the sides. So if we did anything for this child in form of a hemispheric disconnection or a complete hemispherotomy, then the chances of a child developing a severe deficit were pretty high. So we decided, we opted for a TPO disconnection, preserving the tracts, and this child is doing quite well and is seizure free. So I was talking to you earlier about the very first case of my interhemispheric disconnection, hemispherotomy, was this child with holoprosencephaly. This is now almost about 10 years ago. This is about 2011 or 10. This child presented with refractory 14-month-old child. At our center, we have a very, very active pediatric neurologist, and we find that most of our epilepsy work is focused in pediatrics, and we have a large number of large number of cases which are below the age of 5. And we presented a paper recently, when I say recently, this is about 2 years ago, listing our patients with less than 3 years of age. So a large number of these children are below the age of 5, and most of them are below the age of 3. This is one such child, a 14-month-old, and clearly this was a holoprosencephaly with ipsilateral left-sided hemispheric pathology, which was demonstrated on the nuclear imaging and the PET scan, and underwent a hemispherotomy. And this child has remained seizure-free since then. This is an old slide now. And this is another such child, clearly showing This is an 11-month-old child with severe refractory spasms, so almost seizing through the day. And this PET scan has been kept on purpose because this is actually demonstrating an ictal PET, because this is actually hyper at the time of ictus, because the child is constantly seizing and the entire right hemisphere is showing evidence of dysplasia. This child underwent a hemispherotomy, and this was in a lateral hemispherotomy. This was an emergency surgery which was undertaken. To summarize, hemispheric pathology is a very structural, major structural pathology in children needing urgent attention. And the reason why they need urgent attention is because of the encephalopathy that hemispheric pathology leads to, and the child rapidly goes down. Surgical techniques have evolved significantly with much lesser complications with disconnection surgery. And interhemispheric vertical hemispherotomy has an edge. And I'm sure the speaker next, Dr. Sarat Chandra, would give you a much better perspective on the same. Thank you for your attention.
Thank you, Milind. I think that was quite elaborate. And further to what Professor Bhaskar Rao educated us about the medial temporal sclerosis, this is completely different and a different paradigm of epilepsy surgery, where you need to have a understanding of the hemispheric pathology. And Dr. Sankhe just elucidated the technical difficulties and the nuances for disconnection. And if it's done absolutely fine, then the results are quite good. With this, I think with these two talks, I think we can go for discussion for another 10 to 10 minutes. Is that right, Milind?
You have 10 minutes for discussion.
Yeah. So I'm just in the chat box. I'm not seeing any questions at the moment. I've asked Trilok to just send me the questions so that we can audience questions we can directly to you.
I'll read out the questions.
You have the readout? Yeah.
Can I ask a question?
Yes, Sarat, please go ahead.
Milind, that was an excellent talk. I think it was a very good teaching exercise. But I like to add a few things regarding the hemiparesis which develops after hemispherotomy.
Yeah.
Now, while you're right that in most of the atrophic cases, they do not develop a worsening of hemiparesis, we have come across certain exceptions when we have done fMRI, and that has shown a very strong focus on the atrophic side. And when we did surgery, the patient did end up having a significant weakness, which took a long time to improve. In my own center, I have seen it's not very common, but one has to know that such a thing can exist, because when you counsel the patients, you see an atrophic, you'll say, oh, very unlikely, very good. But then the patient develops hemiparesis, then the patient's relatives may get upset. And one of those cases was also in the case which I operated during Ginde's oration. It was an atrophic case where I did an endoscopic approach. But fMRI showed a very strong focus on the atrophic side. And patient did develop a very significant hemiparesis, which took a long time to improve. That's the first thing I wanted to tell. Then second thing is, when we do hemispherotomy, particularly for hemimegalencephaly, in very young children, especially less than 1 year of age, in those children, somehow I don't see a worsening of hemiparesis. They have...
Go on, finish yours. Yeah.
So generally, I find that because we cannot do fMRI in such a young age, but in those kids, I find that, there is not much worsening of hemiparesis. So these were the two exceptions, which I wanted to add. And thirdly, my, this is my advice to people who would do hemispherotomy, saying that hemispherotomy as well as homonymous hemianopia should not be considered as complications.
Definitely not.
Yes, they should be considered as a sequel of the surgical procedure you're doing. And ultimately, they have to understand that the patient would anyway develop a hemiparesis in the due course of disease, but by doing, and would also develop cognitive deficit. But by doing the surgery early, you're just producing a hemiparesis which will improve, and you're preserving or you're stopping the further progress of disease. I think this part in counseling is very, very important.
Absolutely. In fact, one of the major reasons for advising early surgery for any substrate, and there cannot be a bigger substrate or a better substrate than a hemispheric pathology. The biggest substrate, as I said earlier, these lead to encephalopathies, particularly with patients with hemimegalencephaly, or for that matter, with patients who have a hemicortical dysplasia or multiquadrant dysplastic cortex dysplasia. They essentially go into encephalopathic status, which produces long-term sequelae in form of cognitive issues and developmental issues. So, though many a times they would not necessarily have a motor deficit, but at some stage they would have to learn to accept that this child is going to otherwise have a very, very bad outcome from not just the epilepsy point of view, but developmentally, and it will be late. Rather, at least have the epilepsy stopped and have a much better cognitive outcome, and the hemiparesis over a period of time recovers. And obviously, depending on the substrate, it changes. If you have a major infarct, then obviously it's probably less devastating for the family. But if you're talking in terms of someone with a multi-quadrant dysplasia, or for that matter, hemispheric dysplasia, then they find it a little difficult to accept. But nevertheless, I think all efforts are made to explain to them that this is a sequelae and not a complication. Neither should a motor deficit, or for that matter, a visual deficit, be considered a complication. This is a sequelae of this operation, and this is bound to be accepted. It has to be accepted. It's just the way it is put to the patient's family.
What about patients who are having a robust supplementary motor cortex? The supplementary motor cortex on the opposite side, or the motor cortex, they take over the functions on the ipsilateral side of surgery. I think that also, sometimes these patients don't have anything. They don't develop hemiparesis. Sometimes I feel that whether we have disconnected the entire disconnection is done properly or not. But the seizures are getting controlled. Patient doesn't develop hemiparesis. So in that case, do you have any experience whether the opposite side, opposite side is the controlling for both the sides, and hence the patient doesn't develop hemiparesis? When we say that the patient will develop hemiparesis after surgery, Emilin and Sarath both can answer the question.
Yeah, so that's where the role of DTI comes in our practice, and we try and use it very regularly. That is one. Second is the regarding the motor deficits. So motor deficits are less likely to shift to the opposite side, or motor function is less likely to shift to the contralateral side. However, speech is something which shifts very regularly, particularly when it is done at a younger age. So if you're doing a left-sided surgery, I don't think one needs to be worried about the speech at all. The speech will shift, for sure it will shift. Particularly if it is done at a really young age, it will definitely shift, and it will never be noticed by anyone for that matter. Whereas for a motor, one cannot really be sure, though in our experience, I would say that there are a couple of cases where we've had, clearly mentioned, and there's hardly been any change as far as the family is concerned, and there's hardly been any change in the motor deficit. So there, one could have said that, there has been a shift. But then, as Sarath earlier mentioned, doing an fMRI in a young child can be quite a challenge, and it is not easy to try and demonstrate a shift.
Any robustness in the DTI have you seen? Is the DTI more thicker on the contralateral side to suggest that the motor cortex is robust on the opposite side?
Well, one cannot really say about the robustness on the contralateral side. One can try and use the robustness of the DTI tracts on the same side, on the pathological side, to predict what is the possible postoperative motor deficit. But just because it is robust on the contralateral normal side does not mean that it is going to switch from one side to the other. That cannot be predicted as.
Sarath, what is your experience in that?
So now regarding the motor function, I am not too much worried about it if I see that the pincer's grip is absent. So presence or absence of pincer's grip is what is going to be one of the most important things or determinants for me to do a hemispherotomy. Now language function. In an hemimegalencephaly, I'm not too much bothered, especially in a young child, regarding the language function. But if I see an adult with a dominant side hemispherotomy, dominant side hemispheric pathology, I will be very much concerned, because there I do not know how much are shifted. So definitely I like to do an fMRI. Again, in an adult, if it is a atrophic, then again I'm not so much bothered. One of the cases which I will show you, this was a 14-year-old child who had a hemimegalencephaly. So this child was more or less asymptomatic for 7, 8, 9 years, even though she was cognitively retarded. and then started developing seizures at 10 years of age, which is very unusual. Now, in that child, it was a dominant side hemimegalencephaly, and ultimately, I ended up doing a corpus callosotomy with a pan commissurotomy. And with that, the child had reasonably good control of seizures. Because in this child, 14 years of age, I would have been very much, it would have been
a complete.
a difficult decision to do a dominant side hemispherotomy.
Thank you. Bhaskar, you have a comment.
No, I thought among the participants.
Yeah, is there any?
The measure, no. I just want to add one point. Milind, can I add a point?
Sure.
Yes.
Yeah.
So many of the participants may not be familiar with hemispherotomy or hemispherectomy. I thought of sharing 1 or 2 points for their benefit, and Sarath has pointed. First thing is hemispherectomy or hemispherotomy is indicated only when there is a deficit, pre-existing deficit like pincer grip and foot tapping. If there is no deficit, no hemispherotomy in general. Of course, there are exceptions. One exception is there's a progressive pathology like Rasmussen. Even before the onset of deficit, we can.
Even for that matter, hemimegalencephaly.
So that is one. The other thing is, see, the cortex is largely, it's not the neural injury. It's suppose if there's a vascular injury, if there's a basal ganglia injury, then it's not the cortex. That neural injury will cause deficit, which may take long time to recover. I think it's not the shift of function or SMA involvement, to my knowledge. Yeah, I'm done with that.
Okay, I think are there any questions that I would like to ask Bhaskar one question. Bhaskar,
there are questions, Datta. Can I just?
Yes. Can you read?
So one of the questions is maybe Bhaskar, you could answer this. Indications of surgery in non-lesional epilepsy and what other options do we have? In fact, I think this question will probably be answered better when Sarath and Ashwini Saran's talks are over. So I think we can leave that question away.
No, but I'll just give one very, very simple thing. Non-lesional temporal lobe surgery is being done. And centers which perform these procedures, they report almost 50% seizure freedom. See, epilepsy evaluation is multimodal, and MRI showing lesion is just one component. MRI can be normal, but suppose if there's a PET showing hypometabolism, that's an indicator. So most important thing is electroclinical concordance, supported by other evidence like MR negative and PET positive. And even MR negative, always not histology negative. So MR, of course, one may miss the lesion, it can be small lesion, it can be subtle lesion, but histology can be positive. So as the MR detection technique is getting better, we are able to identify more and more lesions. So non-lesional surgery also, if there's a focal seizures, if the semiology is consistent, if it is correlating with electrophysiological focus, if there's other associated supporting evidence like neuropsychology, MEG, PET, SPECT, then one can go ahead with the surgery in those cases also. Of course, at the end of the webinar, we can discuss more with non-lesional surgery.
So there's one more question which is asking for a quotation of the reference for the use of DTI in pre-surgical planning. I will give that quote by the time Sarath finishes or by the end of this webinar. So Datta, you're free to ask your question.
Bhaskar, one question. What is your idea about residual hippocampus?
Sorry, repeat again.
What is your take on residual hippocampus after ATL?
So hippocampus is a 4 to 5 centimeter structure, and then in HS there is a volume reduction. Usual standard textbook description is anterior 2/3, because posterior 1/3, the tail, needs a retraction of the temporal lobe, especially if it happens to be on the dominant side. The retraction can cause language impairment. So it is left in initial series. And in 20% of the cases, especially those failed cases, it was found that the focus is in the posterior part, and then resurgery resulted in good outcome. So now the current practice is to remove as much hippocampus as possible. In general, the epilepsy principle is that maximum removal is good for epilepsy cure. Minimal removal is good for cognitive memory preservation. So one has to strike a balance. I think Sarath wanted to add a point.
Sir, you want to add some point on this residual hippocampus?
There was a very important study by Weiser et al., who was a neurologist to Professor Yasargil, and he studied in detail the cases operated by Professor Yasargil, and he found that whenever the hippocampus was resected till the level of the area where it turns into the atrium, which is at the tail, at the junction, which on the axial section corresponds to the level of colliculus. So till the level of colliculus, if it's resected, these patients ended up having good outcomes. Now, a caveat to this is what has been proposed by Professor Ojiman, where he has proposed tailored hippocampal resections, which many people do not follow. I mean, they go ahead and remove as much hippocampus as possible.
So, hippocampus is concerned with reorganization of memory.
Now, but practically what is important is one should study the MRI very, very carefully and then see which area is involved. And one should always try to go till the level of the colliculus. You cannot do it in toto resection. So you can remove the anterior part at one stage, and at a second stage, you can angle the microscope so that you can visualize the posterior part of the hippocampus and then resect it piecemeal. But the anterior portion has to be resected in toto, so that you have a good specimen for histopathological diagnosis.
And worried about the visual deficit also if you go too much radical into the posterior part.
Datta, your point is that if you leave the tail of the hippocampus, memory is organized better.
Yes, that's what is the new concept which is coming. So I just wanted your opinion on that.
Yeah, it's like a motor sparing hemispherotomy.
Yes.
Okay.
So anything, or should we go ahead? Milind? Should we go ahead?
On to the next one. Yes.
Yeah.
Please.
So after these two fantastic lectures, we go to another deeper into the innovations in epilepsy, and I think Professor Sarath Chandra requires again no introduction. He is the distinguished professor of neurosurgery at the famous All India Institute of Medical Sciences in Delhi, and his experience goes more than 2,000 cases now, and he's as you see his biodata is quite. It will take me another 20 minutes to elaborate. But he is the president-elect of the Indian Epilepsy Society, and he's got he's editor of Neurology India also, and he is much involved with the ILAE. So with this short introduction, I think, Sarath, we are very eager to listen to your radio frequency and endoscopic technique, which is innovative, and I think it is becoming more minimally invasive, minimal access, maximally invasive kind of procedure. Over to you, Sarath.
Thank you so much, Datta, for that very nice introduction. And it is, I think, an honor and a pleasure to be part of this very useful and a very nice symposium, which is covering very important aspects of epilepsy surgery. So in my lecture, I will be speaking about the evolving role of radiofrequency and endoscopic techniques for epilepsy surgery. And I would deal, of course, a lot heavily upon my own personal experience. And before my lecture, I would like to acknowledge all the members of my epilepsy surgical team, particularly to Manjari, my neurologist, and then Dr. Ramesh, my younger colleague, and my fellows, particularly Dr. Raghu, who is there with us now. And we also have a full team of basic scientists who do very advanced work on molecular as well as intracellular electrophysiology. We published more than 100 papers in this area. And then we have also established the Magnetoencephalographic Center at the National Brain Research Center. So like Milind was very nicely, Bhaskar and followed by Milind were very nicely saying, if you look at the randomized controlled trials which have been done for epilepsy surgery, surprisingly, we do not have many. And if you look for resective surgery, we have less than 5, of which only 2 are mostly quoted. One is, of course, by Professor V. et al., where he has shown that there is a significant difference of 58%, 8% versus 8% in patients who have been operated for mesial temporal sclerosis, of those who undergo early surgery versus those who undergo delayed surgery following a trial of medical treatment. But what is more important is you should see that in epilepsy surgery, the number needed to treat is one of the least as compared to any other pathologies, which means that it is going to have a maximum benefit to the patients and hence should be done as early as possible. The next important RCT was, of course, from our center, which was the first ever RCT for children with drug resistant epilepsy. And we have shown a tenfold difference between children who undergo surgery versus those who undergo medical treatment only. And not only that, we have also shown that the secondary outcomes, which are mostly the cognitive outcomes, they were much worse in children who were operated with early medical treatment followed by late surgery. Hence, in children, not only it is important to stop the seizures, but it is also important to prevent further progression of epileptic encephalopathy, for which reason the surgery has to be done as early as possible. Now, doing surgeries in children at an early age again raises the challenge of any other pediatric pathology, which includes blood loss, hypothermia predisposition, and then, of course, most of the children have large lesions. Most of them require hemispheric disconnection. So the challenge is, can we minimize the surgeries which we do so that the surgeries become safer while remaining as efficient as possible? Because obviously, if you have to do hemispheric resections in 2-year or 3-year-old children, it's going to be a big challenge. So the idea, that is what was our idea when we started developing this technologies. Now we have been using endoscope for the past 7 years, and we were the first to develop the technique of endoscopic hemispherotomy as well as endoscopic corpus callosotomy. Now earlier to this endoscope, the only use of endoscope in epilepsy was by the by Professor Rakete, where he showed the effect of endoscopic disconnection for hypothalamic hamartoma. Now if you look at the radio frequency techniques for epilepsy, we could use it for hippocampal sclerosis, for ECG guided ablations, hypothalamic hamartoma, hemispheric disconnections. Similarly, and of course we have two mechanisms of performing a lesion within the brain. So the well tested is radio frequency ablation, which have been applied for thousands of cases. But more recent is a laser ablation, which Ashwini will speak something about. Obviously, it has the advantage of being controlled or guided by the MRI, provides a real-time visualization, has a narrow transition zone as compared to radio frequency ablation, where the transition zone could be as high as 10 millimeters. But that, I think, is an advantage, and I will show it to you later. But the advantages of radio frequency ablation, especially for countries like India, is that it is reusable. It's highly inexpensive. Now, there have been literally thousands of cases done for parenchyma. So it has been established to be quite safe when you're doing parenchymal lesioning. And most important, it could be guided by a robot for multiple trajectories. And in our center, for instance, because it's a government-aided center, they have paid for the robotic system as well as for the radio frequency ablation. It costs the patient only $50 to undergo radio frequency ablation, because you could go on using the probe again and again. As compared to the MRI guided ablations, laser ablations, which could be very expensive, requires an MRI environment, etc. Now, if you look at 1950s and 60s, there have been a number of surgeons who have done practically thousands of cases. So they have used radio frequency ablations for doing dentatolysis, phonecotomies, thalamotomies, hypothalamotomies, amygdalotomies. And from India itself, we have Professor Ramurthy, who has used this technique for more than 600 cases. So sometimes we forget that our forefathers have used this technique in several hundred or thousands of cases. So with this, let us look upon the effect of the usefulness of radio frequency techniques for various pathologies. First, of course, let us speak about hippocampal sclerosis. Now, personally, I don't have any experience of radio frequency ablation, but I think it's a good idea, and I am thinking of starting it again. And if you look at this nice meta-analysis, which has studied 667 patients, it has found that the radio frequency ablation has a class 1 outcome similar to that of laser ablation, which is approximately in the range of 50%, as compared to a surgical, which has surgical outcomes ranging from 60 to 70%. Similarly, if you look at neuropsychiatric outcomes, they are definitely much better in laser ablations as well as radiofrequency ablations as compared to surgical techniques. So it's no wonder that laser ablations have become the first stay of treatment in most of US, because if the patient is seizure free, you have done away with a more minimally invasive procedure. Similarly, the complications are also definitely much less for ablative lesions as well as laser ablations. So this study has concluded that there was not much difference, surprisingly, between radiofrequency ablations and laser ablations, even though surgery is more preferred. And like Bhaskar was saying, in India, we prefer to do an anterior lobe surgery, anterior lobectomy with amygdalohippocampeectomy rather than selective amygdalohippocampeectomy. And there are reasons why we don't prefer selective amygdalohippocampeectomy too much nowadays. Firstly, because of this very nice meta-analysis done by Josephson et al., which have shown that anterior temporal lobectomy with amygdalohippocampeectomy definitely has a better outcome than as compared to selective amygdalohippocampeectomy. And there have been recent studies which have shown that there was not significant neurocognitive outcomes of anterior temporal lobectomy versus selective amygdalohippocampeectomy as thought earlier. Earlier, we used to think that if we remove more tissues, patients are going to be more cognitively retarded, but it's not so, because most of the tissues which we are removing are epileptogenic tissues. And finally, last but not the least, our own lab, Dr. Jyotirmay Banerjee, he did this very complex connectivity studies, and this was published in Scientific Reports Nature, where he demonstrated very nicely for the first time that the extra hippocampal circuits in hippocampal sclerosis are actually much more active than the hippocampal circuits, which provides a strong reason for us to do a much more wider resection if we need to achieve a good seizure freedom outcome. Now let's look at the scope of radiofrequency ablation techniques for SCG. So more recently, even though this is being practiced in France and other European countries since a long time, but can we incorporate radiofrequency ablations with stereoencephalography? Yes, we can, but there are certain important indications for this. The most important indication is that when we sample the epileptogenic networks with SCG, we should have a focal area or a local area, and it should be a limited epileptogenic zone before we think of doing an SCG guided thermocoagulation. So this is the most important indicator, that when you do an SCG sampling, you should have a focal area of resection. It should not be widespread. The objective is obviously we need to disorganize the epileptogenic zone. And more recently, it has been suggested as a palliative procedure, especially for children who have diffuse networks. So in them, you can try multiple SCG guided thermocoagulations if the epileptogenic network is too extensive, but the parents or the relatives have to be explained that this is a palliative procedure. And then, of course, the other important indication objective is to preserve the cognitive outcomes as much as possible, because this is a very minimally invasive procedure. But it's very important to have a good hypothesis. Without having a good hypothesis, you just cannot go and perform a SCG guided thermocoagulation. Now, how do we do it? We do it using a generator. Now, in our center, we use the Cosmos generator, which is recommended. We produce a lesion of 1 minute, ranging from 78 to 82 degrees. Now, initially, for all the cases, initially we try it on an egg white to see whether the generator is working. Even though it's not required, we like to do it because sometimes the generator could malfunction. There is no need for an anesthesia. So once we put an SCG, once the neurologist localized the area, they said, okay, we have a focal networks. We could try SCG guided thermocoagulations. Then we do this in the EEG room itself. And one of the peculiar things about this procedure is that when we complete the radiofrequency ablation, we hear a sound like pop, and this has to be auscultated on the head. And the patient has to be explained that you would hear a noise like pop in your head, and that denotes the completion of the SCG guided thermocoagulation. And once the coagulation is completed, the electrodes can be removed within 4 to 5 hours after doing a CT scan. So I will show you an example, a 30-year-old male who was having the duration of seizures since 23 years, 2 to 3 per week, multiple drugs. Almost all the events were happening on sleep. Localization with video EEG were to the right side, frontal and anterior temporal. Now, neuropsychology obviously showed he was a high functioning individual. He was in IT sector. He had some, you can see the entire neuropsychological profile is completely intact. And that is one of the reasons. And his intellectual functioning was also high average. And he was married, he had a kid. And that's one of the reasons why he was not preferring a resective surgery. Now, when we did an MRI as per epilepsy protocol, we could see a small cortical dysplasia on the posterior parietal area, which was confirmed with the PET MRI fusion. Now, syscos, for some strange reason, showed an activity on the opposite parietal area. Now, fMRI showed a very good preservation of all the functions, and we found that none of the functions were localized to this area except for memory, which you could see is slightly more posteriorly present. Now, if you summarize our findings, the MRI showed a very focal area in the posterior parietal area on the right side. The syscos was on the opposite side. The video EEG showed a wide area as expected, including the frontal as well as the parietal area and temporal areas. Now, we ended up putting 7 SCG electrodes, one in the right hippocampus, one anterior to the FCD, another posterior to the FCD, in the left parieto-occipital sulcus corresponding to the SPECT area, right superior temporal gyrus corresponding to the PET hypometabolism, right parietal opercular area, left parietal opercular area. And this is how the electrodes were placed. Now, we found to our pleasant surprise that all the foci were arising from the anterior part of the focal cortical dysplasia and then progressing to the posterior part. We then stimulated the electrodes and we produced a habitual seizure, further confirming that this indeed was the area of generation of seizures. And again, posterior contacts also we were able to obtain spontaneous discharges, and on stimulation, we were able to stimulate on stimulating to the deeper electrodes, which were closer to the frontal part, got stimulated, produced habitual seizure. And then we produced an SCG guided thermocoagulation. Now I will show you a few images how it is done. So this is the SCG electrode. We tested out an egg white. So you can see it performs a very nice linear thermocoagulation. Now we have this special switch box where we can do an SCG recording first, and then we produce a coagulation. And after that, when we do an SCG recording, the entire recording becomes completely flat, giving us a good confidence that we were able to ablate it completely. And this is the Cosman generator which we use. So you can see the entire procedure is done bedside in the video EEG room itself. Patient is completely awake, and you can see my fellow is auscultating the head, and even the patient hears it, and sometimes, many times, even we can hear it outside. So that pop sound is quite loud, and that indicates the end of doing the thermocoagulation. So what are the outcomes? So the responder rate at 1 month, I'm sorry, this is not 1 year. There's a responder rate at 1 month is approximately 70%. And the at 1 year is approximately again 75%. Now this is not same as seizure freedom. So seizure freedom at 1 month is 43%, which can drop down to as less as 25%. But again, they are well controlled with anti-epileptic drugs. So one has to understand that there are certain limitations to this procedure. One cannot go on doing this for all SCGs implanted. So one has to develop a good hypothesis. There has to be a good localization, and only then one can go ahead and do it. So as the predictors of outcome, obviously, it is very good for gray matter heterotopias. Now, MRI is not a criteria for doing SCG guided thermocoagulation. So focal epilepsies are very important. It is very nice palliative for eloquent cortex could do it. And it is more effective for type 2 focal cortical dysplasias than type 1. And definitely there are certain limitations in pediatric. Only 20% can undergo, but sometimes it could be considered as a palliative measure. Now, speaking about the role of endoscope and radiofrequency ablation for hypothalamic hematomas. We know that hypothalamic hematoma is a very unique and a very fascinating problem which happens in the hypothalamus. And we all know the difference. What is the definition of hypothalamus hematoma? What is the definition of hematoma? Now, all these patients that typically present, as we know, with gelastic epilepsy, rarely they could present with the diachromatic epilepsy. Some of them, approximately 1/4, present with precocious puberty along with psychiatry and behavioral disturbances. About 5 to 10% they present with Pallister-Hall syndrome, which consists of acne over the forehead, as well as syndactyly and polydactyly, and well-developed primary and secondary sexual organs. So this is what is Pallister-Hall syndrome, and I will show you how the gelastic epilepsy looks like. So it looks like bursts of laughter, and the child doesn't like it. So they look like bursts of intermittent laughter, and this is followed by crying because the child really doesn't like it. Now, these are the various types of hypothalamic hematomas as per Professor Delalande's grading. Now, among all the epilepsy substrates, hypothalamic hematomas are the easiest to investigate because just with an MRI and video EEG, you're good to go ahead with surgery. Now, if you look at this paper where we have also contributed, done by the International League Against Epilepsy, which discusses about the diagnostic test utilization for evaluation of resective epilepsy surgery in general in children. So L stands of little use. So you can see that 3D MEG is of little use, PET is of little use, SPECT is of little use, ECOG is also little use, and intraoperative monitoring is also of little use. So the only thing which is very important to make a diagnosis for hypothalamic hematoma is an MRI and video EEG. Yeah, so I will skip this presentation. Now we do have a number of procedures which includes open surgical techniques, radiosurgery, laser ablation, and radiofrequency ablation. Now surgery, I will not recommend it because you're approaching it from the external surface which is covered with blood vessels. It's a maximally invasive procedure. You have to do a large craniotomies. Endoscopic disconnection is also difficult, more or less being given up most of the institutes. Radiosurgery again is not very effective. It could be effective for smaller lesions, but definitely not for larger lesions. And what is settling down for treatment of choice is laser or radiofrequency ablation. And we feel that radiofrequency ablation definitely has a superior edge, and I will show you how it is. So this is the various types of grading. And you could see this is one of the earlier cases where we have done an endoscopic approach from the opposite side using a endoscopic guided with neuronavigation. And you can see this is the disconnection we have done. So it's a difficult procedure to do. But over a period of time, we learned the technique of radiofrequency ablation from Professor Kamiyama, who has done more than, I think now, close to 300 cases. And they have found it very, very safe and very, very efficacious, where you can do multiple trajectories. So taking lessons from them, we developed our own technique of robotic guided hypothalamic hematoma disconnection, and this is how we do it. We have a number of, and we can do multiple trajectories from both the sides whereby we disconnect it. So you can see that we produce a lesioning for about 74 degrees for 60 seconds. I will skip the video for lack of time, but we published this both in Neurology India as well as World Neurosurgery. And you can see that a majority of our patients have had a grade type 1 outcome, grade 1 outcome. And few of them who had grade 4 had a pedicle, which was residual remaining. And we went ahead to do even 3 surgeries, after which they became grade 1. They had a good grade 1 outcome. So doing a repeat surgery is not an issue with radiofrequency ablation because it's a small procedure. So in our study, we found that close to 85% were seizure free, and this correlates very well with the literature available. Now, even the hormone normalizes very nicely, as we have shown in about 25% of the patients where the hormones normalize very nicely. Now, complications include fever or transient visual disturbances, but these were very transient and the procedure was very well tolerated. Few example, it's a type 1 hematoma. This is the pre-op, and this is a post-op where we produced a very nice radiofrequency ablation. Again, MRI post-op. This is a type 2 hematoma. And again, post-operative image showed a good lesion. This is a type 3. Now MRI again shows a very nice lesion which has been produced here. And this is a giant hematoma, which is, I think, practically inoperable by any kind of procedure. Now, problem of laser is that you could always introduce just one electrode inside and keep on burning till it reaches to the entire hematoma. Because of which I feel that laser cannot be done for bigger size hematomas like this. And this kind of hematomas are very much suitable for radiofrequency ablation because you could do multiple trajectories. So in this case, we did 8 trajectories and 34 burns. And then patient had improvement of seizures, but had a small residual pedicle, you can see here. And then came back for the treatment of the residual pedicle. And we again did a second surgery, after which patient was completely seizure free. So we have found that radiofrequency ablation was safe, accurate, effective, faster, frameless, minimally invasive. For us, it was inexpensive, could be repeated as many times as possible. Now, obviously, we found it a bigger advantage over frame-based because it's much more faster, but obviously the robotic system is more example. And definitely we find that it is advantageous over laser ablation because it's all parenchyma. I don't have any vital blood vessels anywhere. And you could perform multiple trajectories, as unlike laser where you can just do a single trajectory and then produce a burn. And then you will have to again do some other trajectories. So these are the papers which we have produced. And then finally, the last part of this lecture would be the hemispheric disconnection. Now, we have been doing hemispherotomy since the year 2005. And this is one of the earliest hemispherotomies. You could see came in status, was having 200 to 300 seizures a day. And just for the learning for the residents, now hemispherotomy is not a uniform surgery. The chief indications includes post-infarct, Rasmussen's, hemimegalencephaly, hemispheric cortical dysplasias, and rarely Sturge-Weber syndrome. So atrophic are easy to do. They have good outcomes. Non-atrophic like hemimegalencephaly are extremely difficult, and they may not have such good outcomes. So we started with a lateral approach in the year 2002, and then shifted to interhemispheric approach. And from 2012 onwards, we developed the endoscopic approach, which was taken up world over. So in endoscopic approach, we use a small opening of 3 into 4 centimeters, where we have an anterior trajectory. And because of the anterior interhemispheric trajectory, you can see that the foot plate of the entire hemispheric disconnection, which is a target, reduces significantly as compared to Delalande's approach, where you go from the top and the foot plate is very, very wide. And that has been one of the biggest advantages of the endoscope. And like Milind has shown very nicely, we have an anterior disconnection, then we have a middle disconnection, which automatically does the insular disconnection also. Then we have a posterior disconnection. And then anteriorly, we also have to excise the amygdala as well as head of hippocampus. For those of you who want to understand more about it, I would suggest that you go through the YouTube videos. So we presented this in the epilepsy surgical techniques. We produced a bunch of papers on this. You can go through it. So we started off initially with atrophic, then progressed to all kinds of complex cases, non-atrophic. And this allowed us to develop the technique of endoscopic corpus callosotomy with commissurotomy. It got into the standard textbooks, very widely acceptable. And then we also published a very interesting paper on the role of the residual temporal stem, which has been neglected in vertical hemispherotomy, which is an area which is just in front of the amygdala. And this was done by my fellow Dr. Shabri Girishan, a very nice work. And by addressing the temporal step in a repeat surgery over here, we were able to enhance our outcome from 80% to 90%, and we published this in JNS. So the temporal stem disconnection, why does it left behind? It gets left behind because it is the deepest area, number one. And then we have to go around the curve, unless we are experts like Robert Carlos, who could curve the ball. Sometimes it's difficult for us to take the endoscope around the curve. And that's the reason it could be left behind, especially in complex pathologies like hemimegalencephaly. In contrast to the peri-insular area, where the deepest area happens to be genu. So if you can see, this was a patient who was operated by a very dear colleague of mine, Professor Sanjeev Bhatia, during Ginde's oration, a patient from Nepal. It was an extremely complex case which took on for almost 8 to 9 hours. There was a lot of blood loss because it was a hemimegalencephaly. And he came back with recurrence about 1 year later, and you could see that the subfrontal disconnection and genu was left behind, because this is the deepest area when you are going through the lateral route. But when we do an endoscope, this becomes the most superficial area. And it just took us about half an hour to do the subfrontal disconnection and disconnecting the genu, after which the child was completely seizure free. So sometimes staging procedures in hemimegalencephaly, one should not think is a failure, rather should think is part of the complex procedure, because sometimes tackling pathologies like hemimegalencephaly is very difficult. So our technique provided a new hope for children by making it minimally invasive. And it also allowed us to develop endoscopic corpus callosotomy with commissurotomy. And we have achieved 100% improvement in drops by using these techniques. And if you go back in literature, we see that commissures were an integral part of epileptogenesis, and they were used by surgeons like Watson and Glue, but later on given up during the surgery. And if you look, the anterior commissure connects both the temporal lobe, and it develops 1 day before the development of corpus callosum. The hippocampal commissure connects the hippocampi, and the posterior commissure, the division of which we described the first time, connects the pars reticularis and the subcortical spread of the Caesars. And like I was saying, this is a patient who was a 16-year-old patient having a hemimegalencephaly, obviously on the dominant side. So we couldn't. This was not a dominant side, but the child was too big for us to do a corpus callosum for doing a hemispherotomy. So we just did a commissurotomy and a corpus callosotomy. We extended the endoscopic approach even to parieto-occipital disconnections. We are now studying this, so you can see a small burr hole, how we are doing parieto-occipital disconnections. And then finally, we introduced the technique of robotic thermocognitive hemispherotomy, or ROCH. And ROCH also indicates a small Arctic bird. I've spoken about it later. And I got this idea when I was treating this giant hematoma, where I thought if I could shift a bit laterally, I would be able to disconnect the entire hemisphere. And that is where we started exploring the feasibility. The idea is, why should we change over from endoscopic hemispherotomy? So obviously, even though it's very effective, but there is definitely a learning curve, and many epilepsy surgeons do find it an issue. So we had a robotic system. That was the birth of an idea. We were able to register it with an O-arm, increasing our accuracy. So you can see that this is an O-arm image as superimposed upon the robotic trajectory, and it increases the accuracy to almost 100%. And then we had this radiofrequency ablation, where we could give an overlap of 2 millimeters to produce a contiguous burns. And then we started calculating how much of trajectories we require for hemispheric disconnection, and we found that just 7 to 10 trajectories are enough for us to produce a disconnection. And because hemispheric disconnection is approximately 1/5 of the cortical plate, and that's where we calculated. So we require 7 to 10 trajectories for middle disconnection, 3 to 4 for amygdala, 3 to 4 for anterior, and about 4 for corpus callosum. And this is how we do the procedure. It's a bloodless procedure. For the sake of modesty, I still say that we lose less than 5 cc of blood, but we drive the robot straight along with adapters straight through the skin. And at the end of the procedure, we remove the robot and put a little bit of glue there to prevent CSF leak, and then take a suture. So we don't even lose 1 cc of blood. It's completely bloodless. So this shows how we do the various disconnections. You could read more about it in the paper which has come up right now in Journal of Neurosurgery. Few examples. 12-year-old child. This was the first case where we did. Yes, I'll stop.
Yeah, okay.
I'll stop.
Thank you.
So for the lack of time, I will stop here. But I can show the last images where we did it for a 6-month-old child with hemispheric dysplasia, and you can see a very nice lesion. And over here, I like to say that radiofrequency ablation is an advantage, because we have a penumbra of almost 10 millimeters in radiofrequency ablation, which allows us to do a complete hemispheric disconnection, which may not be possible in laser. And I think in that way, manner, radio frequency ablation has a bigger advantage than laser disconnection. And this is a child, and you can see the child is seizure free. And very recently, the father has sent me the image. The child is 2 years old now. So I will skip the advantages. And the other advantage, of course, no fever. It's very well tolerated. The child wakes up from the next day onwards, and this is coming up in the cover image of JNS. So we started with a hole in the brain and evolved to a line in the brain. So summarizing, hippocampal sclerosis literature has shown that there is not much difference of radio frequency with laser ablation. However, obviously we prefer open surgeries, but somebody wants to take up, they could take up radio frequency ablation because there have been hundreds of cases done in the past. SCG guided thermocoagulation should be done for focal epilepsy. The SCG localization is more important than MRI, and type 2 focal cortical dysplasias are better than type 1. Pediatrics, sometimes you can consider it for palliative procedure. Hypothalamic hematoma robotic guided radio frequency ablation has become the first procedure of a choice. Hemispheric disconnection, the technique of Roche, which we have developed, is a safe, bloodless, and effective technique. And now we prefer this for all the cases over the endoscopic technique. So thank you very much for this opportunity, and my apologies. I think I've run slightly out of time. Really.
Thank you, Sarath. I think that was quite elaborate, and it is the cutting edge in epilepsy surgery with a lot of experiences will come in the future. I think this is just the start of it. Maybe you have kick-started it, and maybe we generate a lot of experience in this over a period of time. Thank you, Sarath, for this lecture. I think we go to the next lecture before we take the questions. So Professor Ashwini Saran is a very well-known epilepsy and functional neurosurgeon from Thomas Jefferson University in Philadelphia. And I request Professor Bhaskar Rao to show his presentation. I think it's a video recorded presentation which Dr. Bhaskar Rao will be showing. Thank you, Bhaskar.
Yeah, just give me a few seconds.
Yes.
Datta, can you see the presentation?
Yeah, I can see not the entire presentation. I can see your desktop, but not the.
Now, can you see Ashwini's video?
No, we can't see. We can just see the template, but not the video.
I'll just run the. I'll just run it. See.
Hello, everybody.
Yeah, we can
my
hear
name
it.
is Ashwini Sharan. Okay. I'm giving you a pre-recorded presentation on neuromodulation for epilepsy from Philadelphia, USA. I'm sorry that I can't be there in person. I'd love to be with you in India.
Yeah, we have to see the video. We can't see the video.
You not possible?
No, we can't see the video. We are hearing his audio, but not the video. We're not seeing the video.
Yeah, just I'll stop sharing.
Yeah.
I'll restart again. No.
Yes. Yes, we can see now.
You can see the video now. Yeah.
Yes.
Yeah.
Hello, everybody. My name is Ashwini Sharan. I'm giving you a pre-recorded presentation on neuromodulation for epilepsy from Philadelphia, USA. I'm sorry that I can't be there in person. I'd love to be with you in India. I hope the medical situation and everybody's hearts and spirits are strong. We see in the news so much tragedy on what's happening, and we hope, and our prayers are with you, that you recover shortly. Bhaskar, thank you for the opportunity to present some background and work on neuromodulation. In anticipation of this talk, I prepared a little bit of a different amount of content. Neuromodulation, including responsive neurostimulation, deep brain stimulation, VNS, and in the future, I hope to show you drug delivery will be real therapies that we will offer patients. But the nature of this talk is to really speak about some of the advancements and the other applications of the technologies that we have for you. So with that, I'm gonna share my screen and start the talk. So here we go, neuromodulation for epilepsy. So here are my disclosures. I do a lot of clinical trial work. I have a fellowship in epilepsy, and you're welcome to join and apply. We take a lot of both foreign graduates and US graduates in our training program. We have grants that have studied different aspects of epilepsy.
I think the sound is gone. Hello.
Give you some higher level applications of RNS, responsive neurostimulation, deep brain stimulation, as well as VNS, and then talk lastly about seizure freedom and drug delivery. So our goal is really to stop and reduce seizures. I mean, that's truly apparent. And I think the modern age of neuromodulation for epilepsy really started with this article in 2001, which was published in the New England Journal, which actually was a randomized controlled trial of surgery for temporal lobe epilepsy. And it clearly showed that there was a groups of patients that could be made seizure-free. And it was very important, but I'd want to also point out that in that randomized control study, although people quote as high as 70, 80% seizure freedom with temporal lobe surgery, in that study, only 58% in the surgical group were seizure-free at 1 year. Our own institution, a year after that, Mike Sperling, our lead neurologist, published our data. And you can see that 18% of our own patients had class 3, 4, or 5 angle outcomes, meaning that they continue to have symptomatic seizures. So, and there was another 48 patients who also had a class 2 outcome, which means that they had an occasional seizure. So I think that this idea that you can get 70% seizure freedom is okay, but I think everybody should then acknowledge that there's 20, 30% of the patients that we don't help. And that has to be also put in context of the risk of SUDEP, because there are patients who die, who have sudden death from epilepsy, and this has been proven in multiple registries, device registries, epilepsy surgery programs. And so epilepsy is really a problem. And then resective surgery is also not always an option. And I think this has to be kept in context. Some patients have multifocal epilepsy. Sometimes the epileptic focus is in eloquent cortex. There's concerns of cognitive deficits. Surgery is irreversible. And often, I would want to make this point, interestingly enough, you can have false localization. The general paradigm is that we study patients inside the epilepsy monitoring units, the EMUs. Over there, we withdraw medications, we try to sleep deprive our patients. We only study them for a very short time window. And is that really reflective of their condition? This paper showed that 1 in 3 temporal lobe surgery failures could have happened from inaccurate lateralization. I mean, obviously, if somebody had continued seizures after temporal lobe surgery, they were studied, it is not unusual that it will be seen to be from the contralateral side. Or oftentimes, people have bilateral spiking and bilateral seizures. But there's a general philosophy, if 90% or more or higher from one side, perhaps that is the most symptomatic side. But regardless, there is much room for error for inaccurate localization. So with that, I'm going to shift and talk about what do we do in the situations when we cannot provide resective surgery. And that is the nature for neuromodulation. Neuromodulation in and of itself should not be a replacement for resective surgery, but really expands the tool set for drug refractory or drug non-responsive patients. So responsive neurostimulation as a concept and a device idea started in 2004, and it took 9 years for it to achieve FDA approval, which was achieved in 2013. And interestingly enough, within the last few weeks, the company's finally gone public, and there's a lot of public enthusiasm, and I just give you that Yahoo Finance graph. But basically, this is a pacemaker and in sorts a defibrillator. This has sensors. It can actually sense and record from the electrical contacts. You can put paddle or percutaneous type electrodes, depth electrodes, into the cortex, and it can record and then detect seizures. It can store the electrocorticography, and then it can be programmed to deliver stimulation. This is a case of somebody who had seizures in their Broca's region. We put grids and strips to detect the foci, and once we did that, we put these contact stimulations on top of the foci, both to detect the seizure, respond to the seizure, and then stimulate. Typically stimulating at around 100 hertz and 100 millisecond pulse width. And having, in this patient, like I'm showing, probably 90-95% reduction in the number of symptomatic seizures he's experiencing. The results for RNS are very robust. This graph below, you can see a 7-year follow-up study showing 72% reduction, our mean seizure reduction. So it's a therapy that has proven itself over time since 2013. Additionally, seizure reduction is experienced in all lobes. This article by Barbara Jobst and Geller, 2 separate publications, have shown different lobes and their reduction in seizures. Although the most experience is in the temporal lobe regions, it is where we look most often, mesial and lateral temporal lobes, and you can see that there's anywhere from a 60 to 70% reduction. It is as effective for frontal and parietal seizures, and of course for multilobar seizures as well. Now, the more interesting aspect that is emerging now that we have 7 to 10 years experience or more with responsive stimulation is the data component of it. We are able to record long-term seizure trends and detections. The patient is given a programmer and is able to download different parts of their electrocorticography. And in this graph, you can see that with each and every successive programming change, there was a reduction in seizures. And so over the course of 6 months, 7 months, we were able to stabilize and reduce the patient's seizure burden. Additionally, what's also interesting is that we can see circadian patterns or different types of patterns. You can have maybe circadian patterns or ultradian patterns that weren't previously detectable. So the seizure detection system is set up so that it can record different types of changes. They don't always have to be seizures. It could be electrical activity, but you can see that in this patient, in the early AM hours, there's no doubt a trend that there's more seizure activity. And this could be used then to fine titrate different medications and different ways to treat the patient. So we have more tools that the NeuroPace and the RNS system is actually providing us. And additionally, you can see that after adding levetiracetam, the total number of seizure episodes dropped, or the total detections per day dropped after the addition of that drug. So another very interesting use of this technology. And now coming back to this point of lateralization that I alluded to earlier, 2 recent papers that I'm going to highlight from you, one from King Stevens and another one to follow. They looked at how often when patients had bilateral temporal lobe seizures, these patients were mostly implanted with bilateral hippocampal leads, but some actually had strip electrodes as well. But 82 patients they aggregated across multiple centers who had implantation with bilateral leads. And they looked at the time to record the first contralateral seizures. So about 50% of the patients, the average mean for contralateral seizure recording was 13 days. Even 1/3 of the patients had the contralateral seizure recorded 31 days. I mean, beyond 4 weeks after their initial seizure. Now, if you think about what this means, when say patients are in the EMU, unless you plan on keeping them greater than 13 days or beyond 4 weeks, there's a high probability that the patient may have bilateral seizure foci that you will miss. Now that is concerning. It doesn't imply that the contralateral seizure foci is symptomatic or clinically relevant. That's not what this study showed, but it does show significant activity on both sides and the time to detection. This other study by Larry Hirsch was also very interesting because they looked at patients who had bilateral RNS or RNS and eventually went on to have resective surgery. So 157 patients were aggregated from 17 centers, and 24 of them went on to have further surgery. So actually, the 25 went, one was lost to follow-up. But of that 24 patients, 9 were shown to have only unilateral seizures, even though there was some concern that they were having bilateral. The majority of the seizures were unilateral, and after the resective surgery, they all went on to have a curative outcome. Of the bilateral group, 8 or 9 of them went on to have resective surgery because the most symptomatic seizures appeared to be on one side, and they also have very significant reduction. Interestingly enough, the RNS device was left in most every patient. Sometimes they added another electrode to really control and monitor the contralateral side, so as an adjunct tool. But the important message here is with chronic long-term monitoring of the RNS on patients who were suspected to have bilateral lateralization, many more patients, 50% of the patients who had bilateral lateralization continued to be seizure-free on follow-up. So an important tool, nevertheless. So conclusion on the RNS segment, RNS has therapeutic benefit and is robust over time. And we've seen 7-year data showing that. RNS is a very useful tool for seizure tracking. It is incredibly important because it can help us understand and fine-tune medications and its related effects. We can get insight into circadian and ultradian patterns of epilepsy. And of course, it's it could be better at and more natural environment in the patient's life as they're in an outpatient as opposed to being inside an EMU, and give us more accurate lateralization. So next I'm going to speak a little bit about deep brain stimulation. Deep brain stimulation is now FDA approved in the United States since 2018 for stimulation in the anterior nucleus of the thalamus. That's where the study was performed. We have 5-year data showing approximately 70% reduction. That's seen on the graph below. And there's studies now that are showing its use both in central median nucleus, which is a paper here, and also in the substantia nigra for myoclonic epilepsy as well. So there are actually good long-term data showing both its use in a single target and emerging data in multiple targets. Now, since deep brain stimulation, we entered the study phase for this therapy in 2009. So there's probably a decade of experience, even though FDA approval is 3 years ago. And we've learned many things. Like we know that the hippocampus, the fornix, mammillary bodies, temporal lobe atrophies. It's also been shown that the thalamus and specific parts of the thalamus, including the internucleus, VA nucleus, and the dorsomedian nucleus, also can atrophy with time. Not only with increasing age, but also time, and epilepsy also affects the shape of the thalamus. Thalamic variations exist, and the volume decreases with age, and its mean diffusivity also increase with age. So we have to think about the thalamus as a dynamic and not static structure when and if we're going to continue or consider deep brain stimulation. And that's going to affect targeting. I'm going to just refer everybody to 2 papers, one by Warren, which looked at central median nucleus, and then Letemaki, which actually really has done a great job on looking at anterior deep brain thalamic targeting. And I think the most important change has become technical in our understanding of how to get the deep brain stimulation into the thalamus. To get into the anterior nucleus, you can see from these images above, you have to come transventricular. And the most important landmark is to consider the mammillothalamic tract and aim to the confluence of the mammillothalamic tract, which is the outflow of the anterior nucleus. So ideally speaking, you want your contact there. via a transventricular approach. The centromedian nucleus I'll just talk about since it's on this slide is also something that's also done by direct targeting. The coordinates are provided in the Warren paper. It's approximately 10 millimeters lateral to the midline. But interestingly enough, if you do the right sequences, like you see MP RAGE, which really shows the thalamus right, or an F-gator sequence, with an MP RAGE sequence, you can see the pulvinar. And the centromedian nucleus is just anterior to the pulvinar. And then you can see that it's just medial to the VC nucleus and medial to the facial part of the VC nucleus. So if you're using tractography and can get sensory activation, or functional MRI and get sensory activation, you can use additional landmarks to help your visualization, so you don't have to do only indirect targeting. Additionally, the centromedian nucleus is just lateral to the DM, and if you made a line posteriorly from the mammillothalamic tract, it is just lateral to that point as well. So I think there's a combination of direct and indirect targeting that can allow you to get to the centromedian nucleus. Now, there are many surgical nuances that we've discovered now that we're actively performing deep brain stimulation, both in anterior nucleus and centromedian nucleus. There are a lot of veins that get in your way. There are obviously surface veins that you must avoid. There's some closer marginal branches that you have to stay lateral to. And then as you reach transventricular, there's often a vein on the surface, a thalamostriate vein on the surface that you have to avoid. Because of these thalamostriate veins, it's not uncommon. In our practice, we've seen it about 1 out of every 4 cases that we have to then take a posterior trajectory approach. Now, the posterior trajectory approach also has its own different nuances, because as you get the cannula into the target, it tends to displace the brainstem inferiorly. So these are very key points that you need some degree of post-operative or intraoperative imaging to confirm that your electrode is delivered to the right target. The ventricle itself and the ependymal surface is quite slippery and does affect your targeting abilities, and so has to be confirmed. And of course, the cannula has to always be taken to the target. So if you're doing deep brain stimulation for epilepsy, please get confirmatory scans. So some conclusions: the therapeutic benefit of DBS is also robust over time. The anterior nucleus and the centromedian nucleus are key tools key targets that we use. Targeting, like I talked about, has many patients. And of course, do this in the correct patient who you don't have localized epilepsy. And for all those international, since RNS is not yet internationally available, DBS is probably the better option or the only other option in the right patient population. So now I'll speak a little bit on vagal nerve stimulation. This is the longest neuromodulation therapy that we have to date, which is FDA approved. It was FDA approved in 1997. It has 3 electrodes, hooked onto the vagus nerve, and it has many more year data that I'm showing, but typically about a 40% median seizure reduction at 3 years and beyond, and many studies that have shown that. The most recent advancements in vagus nerve stimulation has its recognition that there's an autonomic component to epilepsy. 82% of patients with epilepsy experience rapid heart rate and increase associated with seizures. And if you can actually stimulate and with a triggered autonomic response, you can actually have greater seizure reduction than was previously done with just cycling, which was the programming strategy for VNS. So even VNS continues with a sensor-based approach to make significant advances for our patients with epilepsy. Meta-analysis in multiple randomized studies have also not only shown improvement in partial seizures, mixed seizure types, and generalized epilepsy. And I give for your review this paper published by Dario Englert in 2011, where he did a meta-analysis which included 3 randomized blinded trials, 2 non-blinded trials, and 10 non-blinded, non-randomized prospective studies. So there's clear use for VNS for patients who are not going to opt for brain surgery. It can be done as an outpatient, and of course, it has a much longer history for management and use compared to RNS and DBS. So I'm going to talk a few important points before I get to the final conclusions. But mortality is important in this population. Mike Sperling published our review over a number of years about 1,100 patients in our epilepsy centers and went through Social Security databases to see which patients had survived or not survived. And no doubt that patients who are seizure-free, they have a lower mortality, 5.2 per 1,000 person years. But even patients who have had surgery and are not seizure-free have a substantial reduction from 25 per 1,000 to 10 per 1,000. So even neuromodulation has very significant death benefit for patients with epilepsy. This is also published by Oren Davinsky in 2018 when he looked at patients and their death risk with patients treated with RNS system. So you can see compared to drugs, which also talk about in the placebo arm of patients that actually have SUDEP and epilepsy surgery candidates, but RNS system is very comparable in reducing seizure rate, probably because it gives us so much more information about management of their disease burden, their cycles, and medicine dosing as well. RNS studies have also had, patients have had seizure-free periods. There are 15% of the patients who had mesiotemporal lobe seizures who actually had a seizure-free period, and even patients with neocortical epilepsies describe seizure-free periods. So there has to be substantial death benefit from better control of their seizure burden. And additionally, in DBS, 16% of the patients had a 6-month seizure-free interval, and 8% of the patients in the DBS study and long-term follow-up had a seizure-free interval of greater than 2 years. So you can see that even though it's not long-term or curative disease, has the ability to decrease the burden of seizures, these patients do afford seizure-free intervals. This is a slide and a reference I give to you really just so you have it recorded on your talk, something comparing the blinded period. In the VNS studies, it was 15 to 28% depending on the statistic used, anterior nucleus and RNS about 40% each in the first 3-month blinded period of their study. The rest of the data, when it looks to long-term follow-up, is obviously open label data. So rounding off the talk, sensing makes sense for epilepsy. Seizure detection is important. It's a disease that is sporadic, paroxysmal, can occur at night, and patients are often unaware. So the more we use to sense and use even other biomarkers such as heart rate variability and tachycardia, all these autonomic features, as well as electrocardiograph features, will help us give better control to our patients. And additionally, seizure prediction in the interictal state is something that's going to be better tackled once we have more data on the patients. Stimulation also is important, and I took that slide out, I guess. It's also important because as we've seen with the data, stimulation can reduce, depending on the therapy, VNS, DBS, RNS, anywhere from 40 to 70%. It can have long seizure-free periods and improve outcome. It can preserve cortex and reduce deficits, is reversible, and also has reduced death rates. And the more interesting question is there a disease modification that happens with electrical stimulation over time, with less stimulation burden noted? There are a lot of challenges that will continue to be solved with further advancements in the therapy. We're going to have to decide where to stimulate. We're going to have to decide what to stimulate. Battery life is an issue, and this becomes a cost-related issue. Right now, RNS batteries are lasting about 4 or 5 years, DBS about the same, VNS about 6 or 7 years, but it all has to do with the cycling and stimulation time. If we get to this point of recording, which we have gotten to RNS and other devices that come out, memory and storage will also be a variable. And of course, we'll want to be able to upgrade the software in these systems so we can actually incorporate a closed loop type detection algorithm, which can actually incorporate data on sleep medications and seizure counting. And then the final thing is right now, we just had this talk only looking at electrical delivery. So what next? Will we be able to deliver medications to the brain instead? So this is a project that myself and Dan Abrams have been working on for about a decade. We published in 2020 the first 5 patients who were implanted with an implantable drug through a shunt catheter in the brain. This is dye, and you can see the ventricular distribution and the subarachnoid space distribution. And we were infusing continuously valproic acid with continuous infusion of valproic acid in the first 5 patients, we got a 50 to 90% reduction. And these were in patients who, despite earlier unsuccessful use of oral valproate, responded to direct ventricular infusion, crossing the brain-blood barrier. There were some minor side effects of nausea and appetite loss, but nothing was dose limited. We worked out the final dose, and we're currently in our phase 2b study, and we're actively enrolling in multiple countries now as well. So more to come on that in the future. Anyway, I hope I served the purpose, gave you both an overview of what has been done in neuromodulation for epilepsy, as well as whetted your appetite on applications that will happen in the future. Dhanyavad. Thank you. And hope to see my great in the future.
Thank you very much, Ashwini. And I think both Sarat's talk and Ashwini's talk will generate a lot of questions because this is the in thing. So Milind, are there any questions from the audience that we can take those first?
Hi, Ashwini. Good to see you. Nice that you've joined. Actually, there are no questions related to the last 2 talks, but I'm sure there would be some discussion. There is a question which has been asked at the end of the previous 2 talks, but once we finish the discussion, I'll share the slides to show the references which one gentleman had requested. So go ahead and we can discuss these 2 talks first, because Ashwini, I think, is probably speaking from the theater just now, so I can see him in the changing room just or in the doctor's lab.
So Ashwini and Sarat, I think Sarat also gave a very minimal access, maximum invasive procedures, and Ashwini has given something which is for the future. So both, I think, Ashwini, do you see this coming as a standard of care sometime in the near future, or we have to wait for another 10 years? Just as the data matured for MTS. For the low middle income countries, I think this is a little bit far distant. What are your thoughts on that?
I think, well, thank you for hosting this conference. I think one of the things that I'm most passionate about is helping people understand that the epilepsy surgery techniques are so much different than it used to be 10, 20 years ago. So the bigger message is not so much that I think my desire and hope is that as these technologies get better, it will be more adopted. I think that's the bottom line. I think when a patient, and even most doctors, when they think about brain surgery, they think about aneurysms, hemorrhages, tumors. So they don't realize epilepsy surgery is quite a finesse. And it's a place where anatomy is often not distorted. And so it's very predictable. And so the first aspect of the question is that I think it will be standard of care once the public understands that this is less risky than a heart bypass. Your risk of stroke in having a cardiac bypass is greater than your risk of stroke of having epilepsy brain surgery. Neuromodulation technologies, I think, is interesting because I think the patients will drive it. I think that because this concept of not cutting your brain and changing your brain circuit will drive patients to want to try this first. Now, I don't completely agree with that point of view because patients who had a chance of being cured with resection are then no longer at a seizure death rate risk. So I think that will be the hardest part. And that's when things that Dr. Chandra is doing with minimally invasive techniques will also hopefully change the people's impression that they actually can get through surgery and have great outcome without such great invasiveness.
Thank you. Sarat, Bhaskar and Sarat.
One comment as well, but I'll let Bhaskar finish first. Go on, Bhaskar.
Ashwini, thanks for joining us. The evolution of RNS is very fascinating, leading to resections and a lot of database. Similarly, VNS and DBS did not evolve. Is there there's a natural dead end for those technologies, or?
No, I think, well, I think there'll be, so countries where you can't do RNS, arguably you can do bilateral DBS also in the hippocampus, which I didn't talk about to confound it. So I think until the cost breakpoint becomes where you can have recording systems all over the world, DBS will still exist and VNS will exist because there will be people who are medical failures. And so it's just another therapy form. So I don't think it will disappear in the near future.
No, what I mean is from scientific research point of view,
Yeah.
VNS and DBS did not contribute the way RNS is contributing.
Yeah. No, I think you're right about that. You're inciting it. But I'll tell you what I think is going to happen is, so the new philosophy where people are doing this and it's not proven, and it won't even be DBS, it's going to be strategic ablations. So if you can actually see epileptic circuit in the brain, can you make strategic 1 centimeter ablations in multiple spots? Yeah. So I think that's what's going to win in the near future, and it'll probably be as effective as neuromodulation.
Yeah, I think Sarath will take a lead in those approaches. Sarath, can you just tell the participants regarding the stereo easy electrode and RF? Like RF ablations using the stereo easy small electrodes? Is it different than regular RF electrode or some technical tips?
So SCG guided thermocoagulation is something which has been practiced in France for several years now. It's also rapidly spreading to US, and it definitely, there is a lot of attraction to it because you can do it by the bedside. But what we have to understand is that the hypothesis has to be very strongly driven. Not all cases can do it. So sometimes you can find very focal areas of epilepsy. And so before we do that, yes, you're right. We need to place different type of burn electrodes. So they're not the same as the usual standard SCG electrodes. And then there are certain generators which are compatible with SCG electrodes. You need a good switch box which will be able to both coagulate as well as record the CG so that it becomes a nice elegant system. And you connect the input into the box, and that can be connected into the generator, and then you do it beside the bedside. So it's a bedside procedure, and we are also learning it. We are still in the learning stage of it, but wherever we have done it, we have found excellent results. And you can try it on the egg and see, and then the patient gets this pop sound in his head. You can even auscultate it, and that indicates the end of the thermocoagulation for that particular electrode.
Yeah. If I can ask Ashwini just one more point, I hope this intraventricular delivery of sodium valproate, I hope you are considering Indian centers in your expanded international collaboration. I know you wanted to make it India first, but for some reason it didn't happen. But I hope you will consider India in future.
Yeah, no, definitely will consider India. I mean, I know the enthusiasm was there, and Sarath was with there when we presented it to the national body. But India did not want to be the first.
Yeah,
but it's okay.
Yeah.
So just a question. Just a question and some comments as well. A question is essentially to Sarath. Sarath, the use of RF generator essentially over trying to make it minimally invasive. Now I know you mentioned it, what your results are, but over a period of time, and you can take this as a comment as well, there would be possibilities of some patients not responding the same way. Now, how many patients have you actually had to go and redo is a question, because that's a definite possibility if you're thinking in terms of a hemispheric disconnection using an RF generator, which is really going to be a difficult task, particularly if you're looking at creating multiple lesions for that matter, even irrespective of number of trajectories you make. So how many patients have you had to essentially go back in to try and create a new lesion? And then how difficult was it for you to determine at that stage as to where exactly are you going to make a lesion the next time?
Yes. So thank you, Milind, for asking that question. So we started doing extensive use of radiofrequency ablations for hypothalamic hematomas. And then like the slide I showed you, we treated that giant hypothalamic hematoma, where I got an idea that if you just move a bit laterally, you will actually be able to do a hemispheric disconnection. Now our experience in hypothalamic hematomas has been very good. So 4 of our patients of hypothalamic hematomas required a repeat surgery. They had a class 4 outcome. and 2 of these required a third surgery. But after that, they became grade 1. Because that is a substrate where if you perform a complete disconnection, you are really going to have good outcomes. And that's when we thought, let us try to translate it into hemispherotomy. And then we came up with this paper of Roch, which is now published in JNS. And Professor Rutka has very kindly agreed to put that picture on the cover page also, because it's a very unique kind of a procedure. And when we did the first case for hemispherotomy, it takes a lot of time. It takes almost 9 to 10 hours to do it, but you do it through twist drills and stitches. But the best part is after the surgery is over, the patient wakes up crystal clear, unlike any other kind of hemispheric disconnections. We did it in a 6-month-old child who had a non-atrophic hemispheric cortical dysplasia. It took us about 100 lesions and about 9 hours. It was a small brain. But as soon as the surgery was over, the child was awake. There was absolutely, so unlike most of the endoscopic procedures, where we had to electively ventilate the child. And the best part is the post-operative course. It's complete, the temperature is an absolute flat line. In most of the endoscopic procedures, we have some fevers going on. We need to give some drugs like bromocriptine or even propranolol to reduce the neurogenic fever and all that. And then, but over here, there is absolutely, it's completely flat, and patient is ready for discharge by 3rd or 4th day, which I think is amazing, because for a procedure like hemispherotomy, you have the child ready for discharge in 3rd or 4th day. It's very good. Now, like I've told you, the time what it takes for doing the Roch is because of the limitation of the technology. So if we were to have an electrode with multiple burn points, that means we could finish the entire procedure theoretically in 25 minutes. So if some company were to design a radio frequency electrode which has got multiple burn points, you can finish the whole procedure in 25 minutes. And furthermore, it's a repetitive procedure. So it always provides an exciting future opportunities for automated hemispheric disconnection. So that way the duration can be reduced, I think, when the technology evolves. But I think our entire team is completely sold on it. So we're not going to shift back to endoscopic procedures. It's an amazing procedure. Moment the procedure is over, the child is completely alert. There is not even a drop of blood loss. For the sake of modesty, I had to say that less than 5 cc. But if you see the videos, there is not even a drop of blood loss. You drill it right through the skin using an adapter and then put a stitch on the skin itself. And then we devised this X technique. So X technique is through a single twist drill, you can actually pass 3 trajectories. So even though these are diverging trajectories, but because the hemispheric disconnection is from the floor of the ventricle of the lateral horn till the roof of the temporal horn, so these diverging trajectories more or less act like parallel trajectories, and they end up providing us a very beautiful contiguous disconnection. So using this X technique, we were able to provide very nice disconnection and also reduce the number of twist drills. So and in our case of 6 cases, we had to repeat only 1 case because we did not use the X technique there. But the moment we started using the X technique, we were able to do a continuous contiguous disconnection. And lastly, but not the least, I think radio frequency ablation has an advantage. Recently, there has been a case report published from Harvard, Boston, in Journal of Neurosurgery Pediatrics, where they used a laser ablation to produce a hemispheric disconnection. But I think the biggest disadvantage of the laser is the advantage of laser itself, because the laser is so pinpoint that even if you have some skip area in between, that is going to be functional. Whereas in radio frequency ablation, because you're going through parenchyma, you have a penumbra of almost 5 to 10 millimeters. So even if there is a skip area, most likely that is going to be taken care of.
Sure. So that is quite well understood, and thank you. But I think it is still going to be a little open for debate, because as we all know, for movement disorders or for all that lesional surgery that we do, that there is always some recovery which happens in the penumbra area. So that's one. And the second question essentially was to Ashwini. Ashwini, there's a lot of work which goes on in the US on the anterior nucleus of the thalamus, but one can't really say that it's necessarily the best for anything but for frontal epilepsy, wouldn't you? So anything which is not essentially frontal, but slightly more parietal or different extratemporal would. So if you could just highlight the use of the nucleus that you will choose as the target in DBS for epilepsy, depending upon the kind of epilepsy, rather than just using the anterior nucleus. So essentially highlighting the use of anterior nucleus and the centromedian nucleus.
Ashwini, Ash,
You have to.
Yeah, sorry. No, it's a very good point. Milan, thank you for the question. The anterior nucleus is most part of the limbic Papez circuit. So it really should be the, your hypothesis is that this is a non-resectable temporal lobe seizure. Now, just to be fair, in the study, they didn't use that as a criteria. So, and they didn't actually do a sub-analysis on the different types of epilepsy based on a circuit analysis. They really just looked at partial seizures with impaired awareness. So arguably, if you looked at a population, partial seizures with impaired awareness, but logically in our practice, we use it for temporal lobe region epilepsy. Now, when people actually have more generalized or tonic-clonic seizures, because the centromedian has activation, reticular activation, pretectal inputs to the brainstem, we use it more for the generalized epilepsies as a different target. If somebody has non-specific parietal, occipital, and even sometimes frontal, our tendency is still to shy away from DBS. So I think there is some circuit tendencies. There is some data that people have actually looked at doing more substantia nigra stimulation as well, but the world literature on that is very lacking.
True.
I think.
So there are some questions which were asked earlier. Are there any other questions to the Ashwini or to Sarath? Because there are some questions which have been asked from the audience, and I would like to show a couple of slides for that question. Do you have any other questions, or otherwise I'll share my. I'll just
you can go ahead and
share my screen.
Okay, very nice seeing you, everybody. I'm gonna jump back into.
Thanks, Ashwini.
Thank you, Ashwini.
Thanks.
Bye.
Thanks. Bye, Ashwini.
Bye.
So there was one question which was asked from the audience regarding the, they wanted references regarding the use of DTI, and these are the references. I presume my slide is, my screen is visible. Is my screen visible, Datta?
Yes, it's visible.
So basically, there are multiple references, and these references are seen in the JNS as well as in neuroradiology, and I hope the gentleman who asked this question is able to see this. And then in addition, there's one more reference which I wanted to quote regarding the epileptic encephalopathy, which happens in patients with large substrate hemispheric epilepsy. And so this is the other reference which I was talking about. So with that, I would like to just stop sharing. So is there anything else? Any other questions? Maybe you could finalize and close.
I think it has been a very good meeting, and I thank Professor Bhaskar Rao and Milind for from the ISSFN to put up a fantastic epilepsy surgery seminar, right from the basic MTS to the innovative procedures. And I think audience also must have had a good information about the same. So I think with that, I thank all the speakers and the participants. And over to you, Bhaskar and Milind, for the concluding marks from the ISSFN.
Yeah, actually, last 3 epilepsy surgery webinars must have given a good introduction and maybe a little bit of motivation to young neurosurgeons to take it up. But please don't start epilepsy surgery tomorrow. You visit a center where it's being performed on a regular basis, spend some time, learn all the tricks of the trade, and then take help from people who are already doing, and then there are about 40 plus centers are there in India. You get them involved in when you want to develop your program. And all of us at ISSFN are available at any time for whatever help you need. And thank you very much from my end. Thank you.
Milind, anything?
Yeah, essentially, thank you, Datta. Thank you, Sarath. Thank you, Datta, for moderating, and thank you, Sarath, for being with us. And I hope that all the pioneering work that has been going on in epilepsy acts as an inspiration to many young neurosurgeons and students who should take up epilepsy surgery along with their neurology colleagues and help the cause of epilepsy in India. Just as for the viewers and for the young neurosurgeons, we would like to get your inputs as well. At the moment, I do not have a mechanism by which I can receive a feedback, but I would like to let you know that we've had a regular viewership of these webinars, and each time we've had about more than 300 viewers each time, and so have we had this time at about 300 viewers, 294 to be precise. And I hope that they've been maintaining continuity in these webinars to try and get a complete understanding of the topic before you take up the epilepsy surgery. Finally, the ISSFN website will have these will have all these webinars loaded and uploaded with these talks. So you can visit this webinars again at your leisure and try and rekindle your memory to whatever you have missed, or for that matter, regenerate your interest. So please visit the ISSFN website, and you're also being encouraged to try and take up more membership if you can, because that would give you access to not only the webinars, but to the other activities of ISSFN. Finally, with that, I'd like to thank Sarath and Datta and Bhaskar once again. And thank you for the audience. Thank you to the viewers as well. Thank you.
Thank you, Bhaskar, Sarath, and Milind. Bye.
Thank you.
Stay safe
Stay safe. Yeah.
through a difficult time.
Yes,
Stay
yes.
safe, everybody.
Bye-bye.
Sure. Bye. See you.
Bye.
Bye.
Be blessed by the divine. Yeah, bye.